Hello, my dear friend. A very warm welcome to all of you. In this session, we are going to discuss this INICET PYQs. And usually we get PYQs between 2018 to 2025 in most of the apps or places. But it will give you a clear advantage if you also know the PYQ which came before 2018, let's say in 2015, 16, 17 also. And maybe you can say that those PYQ are old, they will not come. But think from examiner point of view. If examiner has to give question for exam, do you think every examiner will have time to create new question and then put in the exam? Of course not. And so what they will do, they will mostly use the question being asked and change the language and put it again, or they can directly put it also. Plus one more thing is that examiner is someone who will not purchase any question bank or he will not watch any GT or any module or something like that. And he don't have money to invest there. So that is why if you know the last 10 year of INICET PYQ with explanation of the topics, then you have a very clear advantage that you can score very high in your INICET exam. So not just in PSM, also try in other subject to get that extra edge by doing the PYQ not only till 18 to 25, but from 15 to 16, 17 also. And if you have not done 7 year of INICET PYQ till now, please do revise it. That is the most mark giving area which you have to read. So let's start with this question of demographic cycle being asked again and again. If they say late expanding stage of population in India is due to, so which correspond to late expanding stage, A, B, C, D, can you answer? Always pause the video, answer it yourself first, then listen to our explanation. Otherwise, you will not practice recall. And in exam, they never test your intelligence or smartness. They only tell under exam pressure, can you recall from your memory or not? So whenever you see any PYQ session, make it a recall session for your own advantage. Because if you can recall at home, you can recall easily in exam also. So keep doing the recall practice for sure. So here, one thing is, if they're saying about late expanding stage, I hope you know, it's very easy to remember the all demographic cycle. The first and fourth are high stationary and low stationary. And in high stationary, everything is high. Low stationary, everything is low. And like birth rate, death rate, both are high in high stationary, and birth rate, death rate, both are low in low stationary. So this part they never ask. They only ask from two intermediate part, early expanding or late expanding. So do remember, in early expanding also birth rate is high. So they can ask this question in a different way. Which two stage birth rate is high? Birth rate is high in high stationary and early expanding, first two phase. So if any question have birth rate high, that will not be the answer for late expanding. Second thing is, when India go to late expanding, at that time birth rate started decreasing. This was the time after, you can say, 1970s and all, when birth rate also start decreasing because of advancement in medical sciences. And then death rate decreases further, because in the early expanding, only remember these two phases mainly, early and late expanding. In early expanding, birth rate is high and death rate is something which start decreasing due to delivery in government hospital and decrease infant and mother death rate start decreasing. So do remember, this is the difference part. In early expanding, birth rate is high and death rate start decreasing. In late expanding, birth rate start decreasing and death rate decreases further, keep on decreasing. And then the fourth stage is low stationary, where birth rate, death rate both are low. And I hope you all know, declining means birth rate become less than death rate. For example, in last 2 years in China, the birth rate is less than death. So China is also started declining, and mark my word, within next 7 to 10 years, India will also start declining. So which phase will you put late expanding? Can you answer? Let's go. Birth rate is stationary. No, birth rate start decreasing. So stationary is not correct for late expanding. Death rate declines more than birth rate. Yeah, we can say that, because birth rate has just started decreasing and death rate is decreasing further. So it can be correct. Now, if you look at the third option, birth rate decline, death rate same. No, death rate can never be the same. It is either high or in high stationary, then it start decreasing, decreases further, and then it become low. And in the declining phase, death rate become very low. So death rate is never same. Birth rate is less than death rate. If birth rate is less than death rate, this phase is known as declining, where most of the developed country goes, and now China also goes there. And according to the population expert, by now America should have also entered into declining, but America is till now in late expanding, in low stationary, because lakhs of Indian migrate every year to America, and we Indian have the capacity that we can maintain the growth rate of a whole country. America should be really like on our leg, it should be, because we are helping those poor country. So do remember that declining is the phase where China and developed country are there. So when birth rate is less than death rate, it is declining. So it can also not be the answer. So correct answer is death rate decline more than birth rate, because in late expanding where India is right now, birth rate start decreasing. So birth rate has just started decreasing, but death rate decreases further, death rate decline more. That's why the answer is B. So they can create confusing option, but if you know those 5 phases well, you can do it. Next question is, all of the following is larval control measure except Paris green is something which can kill larva also, adult also. Gambusia and guppy, these are the larvicidal fish. And very recently in INICET they have asked what is the larvicidal drug. So Temifos and abate, they are the larvicidal drug along with Paris green. Temifos, abate, Paris green, they can kill only larva, not adult. Gambusia and guppy, they eat the larva. Intermittent irrigation is the best method for rural malaria control. देखो इंटरमिटेंट इरिगेशन का मतलब क्या है, रुक रुक के सिंचाई. रुक रुक के सिंचाई का मतलब कि भाई खेतों में आपको ही पता है, धान के खेत में किसान इतना सारा पानी एक साथ छोड़ देते हैं. सरकार कहती है कि एक साथ इतना पानी छोड़ोगे तो मच्छर भी ब्रीड करेंगे, पानी भी वेस्ट होगा, तो पहले 3-4 दिन के लिए पानी छोड़ो, फिर 3-4 दिन के लिए, फिर 3-4 दिन के लिए, रुक रुक के सिंचाई करो, है ना. Intermittent irrigation, in place of throwing this much of water for 12 days, which can lead to wastage of water plus mosquito breeding, government say throw 3-day water in field, then 3-4 day water, then 3-4 day water, so that less water wastage is there and less mosquito breeding is there. So that is the best method for rural malaria control, because if we are putting less water in the field in every 3 days, then less mosquito breeding will be there and vector control will be there. So best strategy for malaria control is don't let the larva take birth. Vector control is the best method. But in the vector control in rural area, intermittent irrigation is best, and in urban area, covering overhead water tank is the best method. So you should know this: rural malaria, intermittent irrigation; urban malaria, covering overhead water tank. Urban malaria is also decreased by clearing the drainage areas and preventing water accumulation around construction site. But this is also one of the very important area, covering overhead water tank. Because if you go to the rooftop of your own hostel also, you will find most of the roof tanki is not closed. They provide a very good ground for breeding of Aedes mosquito. So for dengue control, Aedes and Anopheles both, because it is clean water in the water tank. So do remember that Paris green is killing both. Gambusia is larvicidal, guppy, Gambusia larvicidal fish, Temifos abate are larvicidal drug along with Paris green. DDT is the only thing which do not kill larva. DDT or malathion, they are the one, or pyrethrum, they are the one which kill the adult. They don't kill the larva. And DDT and malathion are chemical contact poison. So mosquitoes start dying when they come in contact. And pyrethrum is something which is natural contact poison, because pyrethrum come from the plant Chrysanthemum. One more question that they can ask from here is that which is preferred in our national program, DDT or malathion, which we like in our national program. So DDT is something which is banned in India because it can deposit in fat tissue and can cause toxicity. But do you think we Indian are worried about toxicity? Not at all. And we are toxic ourselves. So of course, DDT is something which is still, it is written in PARC that it is preferred in national program. Okay, although it is toxic, but in India we prefer it. Why we prefer it? What is the logic? The logic is, if you are spraying malathion, malathion is respray after 3 months. But if you respray DDT, DDT is resprayed after 6 months. And this question they have already asked in NEET exam also, that what is the frequency of respray of malathion? So remember, malathion in 3 months and DDT in 6 months. Okay, चलो आगे देखते हैं. Which of the following statement about DDT is false? आ ही गया. Residual effect is for 18 months. No, DDT residual effect is for 6 months. So this line, that residual effect of DDT is 18 months, is wrong. Not correct, false they were asking, and D is false. But let's learn the other part. As I said, DDT, malathion, pyrethrum, they all are contact poison. But pyrethrum is a natural contact poison, so it works along with DDT. They have synergistic action. And it immediately kill the prey. Yes, it do not take much time, not so immediate, but not delayed also. Because it's a contact poison. That is why we call them contact poison DDT, because it kills the prey after coming in contact. Chalo. Next thing is, incineration is not done for. I hope you all know, incineration is for yellow category. And if you know yellow category well, you can do most of the question of biomedical waste easily. And don't try to remember yellow with any mnemonic. Because if you will use mnemonic, first you have to decode it, then write it. It's unnecessary bothering. Just remember it with a simple, lively example. Suppose after taking the class, I went out on the road and a truck went over my leg and hand both. And I am without hand and leg now. I am a phocomelia baby. So my body is brought to you and you cut both my leg, both my hand, and left some part hanging in between only. So if you cut my leg and hand, this is anatomical waste. Where will you throw it? In yellow. Then after cutting, there will be blood in the bed sheet. So where will you throw the blood and liquid waste? Again in yellow category. Then you will feel that the bed sheet is soiled because of my blood. So where will you throw the soiled waste? Soiled matlab ganda. So the soiled waste also include cotton, it include bed sheet, anything. That will also go in yellow. Then you will use some medicine for my treatment. And if the medicine is left after use or is expired, where will you throw that medicine? So that is also going in yellow. Expired medicine or remaining medicine. Then you will take my blood sample to know which drug will work on me, which drug my blood is resistant. So for that, you will grow my blood in a culture media to know the antibody, to know the antibiotic sensitivity and all. So that is all the culture media, all the microbiological waste also come under it. Okay. And then last thing is, all the cytotoxic waste come under it. So how to remember it? Very simple. Let's remember the story. First anatomical, then blood came out, then bedsheet gets soiled, then you use some medicine, then you took my blood for antibiotic sensitivity. So all the 5 things are clear, I hope. And last is the cytotoxic. Now one very interesting question came in recent exam in NEET from this part, that do you use chlorinated bag or non-chlorinated bag to store yellow category? So remember, chlorinated bag are no more in use. I also initially thought that it can be chlorinated, but chlorinated bag are removed from use. Now we only have non-chlorinated plastic bag for red and yellow both. Okay. So definitely yellow part, if you remember, red is very simple. It have all plastic and rubber. Plastic and rubber. Now the main confusion comes from waste SARP, because they say waste SARP should go in white. But if I ask about Caesar, Canchi, where will you throw the Caesar? So Caesar is something which we can use after one time. So all the metallic instrument that we can use after one time, they do not go in white. Remember, glasses and metallic instrument, they are going in yellow, in blue. Glasses and metallic instrument, they are going in blue. And we use a cardboard box to store them. Then we put them in autoclave machine, and we reuse metallic instrument and recycle the glass. So when we talk about SARP, it's not all SARP which go in white. Remember this point. In the white category, we have only 4 things. One is the scalpel, because if you see the surgical scalpel, this is the blade and this is the holder. You cannot remove the blade, and if you use it once, then you cannot use it on other patient because the edge will get blunt. So remember, scalpel is the only instrument which go in white. Other than a scalpel, there is needle with fixed injection with fixed needle, because if the needle is fixed, now you cannot throw the injection in red and needle in white because it is fixed. So injection with fixed needle goes in white. Other than that, in white category, you have all needle and all suture also is a type of needle, all needle and blade. So definitely all needle and blade go there. But other than that, there is injection with fixed needle and scalpel also goes in white. So we have revised everything, but do remember, if they ask PPE kit, PPE kit is something which was originally made up of plastic. And the mask material PPE kit is just a jugaad. It's a temporary arrangement. It's not a real PPE kit. So because PPE kit is made up of plastic initially, the real PPE kit with white color PPE kit and blue color chain, therefore it goes in red. And other than that, if you are confused about anything that where to throw this thing, you can ask it on the chat box, definitely on YouTube, and we will discuss it that also. So here, when we look of incineration, it is definitely cytotoxic drug which come in yellow, so we can incinerate. Cotton contained in with blood is soiled waste, so we can incinerate. Human tissue is anatomical waste, and most common anatomical waste is placenta, so that also come under it. But waste SARP goes under white category. So it do not thrown under incineration. Whatever we throw in white, after throwing it in white, we cut them into fine pieces. That is known as threading, cutting into fine pieces. And then we recycle that. So that's for waste SARP. Chalo. Next question. In a study in UK, an association was found between a scale of anti-asthmatic drug and an increase in death due to side effect of anti-asthmatic. This type of a study is. So what they are talking about is sale of some drug. And whenever they talk about sale data come from population. So this is a population data given to you. And then they are saying death, increase in death. Where we will get the data of death? Many times we get the data of death from hospital. So this is hospital data, which is death data. And they are correlating these two. Anti-asthmatic drug is selling high, death rate is high. So they are correlating these two data. And that's why this study is known as correlational study. And other name of correlational study is ecological study. So ecological is correlational. Chalo, let me see any question from biomedical waste or any part. If you have, you can chat mein aa raha hai kya? So you can always let me know if there is any doubt. Okay. Chalo. So this will be ecological study. Now the next question is the best method to compare new test and gold standard. This is an old forgotten question, but has been asked 2 times in INICET. This is Bland and Altman analysis. We do this analysis to know new test and gold standard. Correlational study or correlation study is something which we get by using scatter plot. Scatter plot is dot plot actually. And suppose we are plotting your height. When it will increase, the weight will increase. So this type of dots will come. This is the correlational study scatter plot. And remember, Bland and Altman is for gold standard. Which of the following affect the equilibrium in Hardy-Weinberg law except? So what is Hardy-Weinberg law? It's something which say that the sum total of all the population, all the gene in a population remain constant. That means if you add the dominant gene and recessive gene, the total will remain 1. So sum total of gene pool remain constant. This is Hardy-Weinberg equilibrium. Equilibrium means everything is constant. But this equilibrium is disturbed by 5 method. Tell me, Which type of breeding is good for nature? Random mating or selective mating? Like in India, we mostly marries in caste, our caste. So caste mating is random or selective? And which type of mating is good? So equilibrium is disturbed by five methods. Disturbed by five methods. First method is this caste-based breeding. Whenever it is caste-based, then gene pool do not expand. Random mating is good for nature. And whenever there is selective breeding or selective mating, it disturbs the gene pool. Like for example, the caste system came in India around after 1300. And if you look at the gene pool, it started decreasing after that time rather than expanding. So selective mating is disturbing equilibrium. Other than that, there is migration, which always disturb equilibrium. Then there is the, other than migration, there is sometimes the government initiative government work can disturb equilibrium. For example, a very good question came in one of the exam was that if you are giving good supportive environment to Down syndrome children for their better personality development, is it positive eugenics, positive euthenics, or negative eugenics? So do remember, eugenics means improving the gene pool of a population. And how you can improve the gene pool? One method is what Hitler did. He said that no people who have disability can produce children, and he prevented a lot of people from producing children in future, which is considered as one of the reason of improving gene pool of Germany in future. So this government initiative of Hitler was example of negative eugenics, because he was preventing people from breeding. He was doing a negative work to improve the gene pool. So that's negative eugenics. And suppose if someone is using the sperm of Virat Kohli to produce good children in future, that type of thing is positive eugenics. Okay, when you use sperm, artificial insemination is positive in eugenics. Other than that, if you look into this thing which I said, a movie is also there, Sitare Zameen Pe. They are asking Down syndrome people to play basketball for their development and all. So this is known as euthenics. Euthenics means we cannot improve gene always. So euthenics simply says that whatever gene the child is born, it's okay. We should improve the environmental condition which lead to expression of that gene. Like the Down syndrome children are getting training. So it is letting the gene to be expressed completely. That is euthenics. Okay, training to Down syndrome people and all is very good example to it. Training to Down syndrome. Okay, and that is one example. And then there can be some other example also, like whenever we give good environment for expression of gene, that is euthenics. So the third thing which can disturb equilibrium is government initiative, like Hitler did government initiative, that negative eugenics, that is also a example how we can affect gene pool. The fourth method which can affect gene pool is mutation, like all the X-Men series and all. And the fifth method is natural selection. Okay, so these are the five methods which affect gene pool. Do remember, selective mating, migration, government initiative, mutation, and natural selection. Other than these five, no method disturb Hardy-Weinberg law. So the question is, which of the following do not affect Hardy-Weinberg law, except which do not affect Hardy-Weinberg law? So a small population will not affect it. Small population is something which occur by migration. So like migration lead to some small people going other places. And we have heard that migration is something which affect the equilibrium. Selective mating also affect or disturb equilibrium, but random mating do not disturb equilibrium. So which do not disturb equilibrium? Random mating do not disturb it. Migration, gene mutation, gene flow migration, all of them can disturb the equilibrium. Okay, so I hope you will remember, random mating do not disturb the equilibrium. Now next question is, You have diagnosed a patient as having SLE and order 6 tests, out of which 4 tests has came positive, 2 is negative. So the probability of SLE at this point, what you need to know. So this probability of SLE is decided by Bayes theorem. Bayes theorem simply say probability of disease out of total positive, and disease out of positive. Because if 100 people came positive, not all have disease. So probability of disease out of positive is dependent on two things. It is sensitivity into prevalence divided by total positive. So what does it mean? It means if a disease is rare, for example, you might have heard Sudha Murthy saying in parliament that we should do cervical cancer screening of all female of India. So cancer is which type of disease? Cervical cancer which type of disease? It's a rare disease. And because it's a rare disease, so prevalence is very low. If prevalence is low and you do cervical cancer screening, then people who will come positive, very few of them will have the disease. Many female will get false positive report. And this has occurred already in Chhattisgarh tribal area. When I went to work after my PG, I found that in that area, they already did cervical cancer screening among female. And many female come in OPD with positive cervical cancer report. And I asked that, okay, this reporting was done 3 years back. Did you had any symptom in last 3 years? They said nothing. I said, then it means it is false positive. You were not having cervical cancer because cervical cancer is a rare disease. So out of the positive result, probability of disease will be very less. You will not be having the disease actually. You just came false positive. So if Indian government did cervical cancer mass screening, many false positive will come out. And Indian health system is not capable of handling the real positive. So they can be overwhelmed by these number of false positive. That's why it's in US, UK, it can be done. But in India, implementing such suggestion of mass screening can be an overburden to the government health system. But I respect the lady, Sudha Murthy is a good lady, but that logic of doing mass screening for rare disease is not correct, especially if the health system is not good like in India. So do remember, whenever we want to know the positive predictive value, this is PPV, positive predictive value. Probability of disease out of positive result is PPV. It depends on sensitivity, it depends on specificity, but it also depends on prior probability of SLE. Prior probability means prevalence of SLE. If SLE is common in that area, then we can do the screening and we can trust on the positive report. But if SLE is rare in that area, then PPV will be less. This question has came in another way in NEET exam, that PPV is directly proportional to prevalence. Okay, what does it mean? It means if disease is common, PPV will be more. Prevalence means total case, old plus new case at present moment. Old plus new, whatever people are suffering, they all come under prevalence. If you have not recovered yet, you are counted as a disease person, and disease person number is prevalence. So the point is, the positive predictive value is dependent on prevalence. That means if you do pap smear among sex worker, in which the prevalence of cervical cancer is more, PPV of pap smear will be higher. And if you do PPV in female who are normal, not sex worker, then in them, because prevalence of cervical cancer is low, PPV of pap smear will also be low in normal female and it will be high in sex worker. So do remember, if you want to know, determine the probability of SLE is correct or not, you need 3 things for it: prevalence, sensitivity, specificity. This question they can turn and ask in a third way also, that diagnostic power depend on which 3 things. So diagnostic power is same thing as accuracy, and diagnostic power or accuracy depend on 3 things. Which 3 things? Prevalence, sensitivity, specificity. So do remember the 3 questions which we discussed from here: sensitivity, specificity, and prevalence. They decide the diagnostic power or accuracy. Second point, prevalence is directly proportional to PPV. Third point, that if you are getting a positive result, whether or not you are diseased depend on 3 things: sensitivity, specificity, and prior probability, that means prevalence. Okay, but we will come back to that point that sex worker and high cervical cancer is actually not a correct thing to say. But why it's not a correct thing to say, because let me give you this yes, what they are trying to say is that sex worker, they have high risk of, high chance of cervical cancer. And I have read it in my time also, in gynae book they write it, ki why sex worker has more cervical cancer? Due to multiple sexual partner. So basically they are saying that multiple sexual partner is causing more cervical cancer. They are trying to say this indirectly. And in this story, this is not a correct picture. Why? Because whenever they talk about sexual partner, multiple sexual partner, they are not asking this history from normal female. They are asking this history from sex worker. And in sex worker, we all know that there is high cases of drinking alcohol. Sex worker are high chance of smoking also. Sex worker have high chance of poor hygiene also. Sex worker have high stress also, because everyone is coming and using them only, rather than some true friend or true connection they are missing. So they are under stress, and I think stress is the reason for most of the cancer and diabetes also in the main way. Then of course they also have decreased sleep, because they work during night, so they have less sleep. So all these 5 factors, they can cause cancer also now. Why to blame it on sex? So basically I want to say that do as much sex as you want to do. Sex is not causing cervical cancer. It's the other factor which scientists did not look. They are causing actually cervical cancer. So all these factors which are outside factor, which is related to both exposure and outcome, this is known as confounder. Because in this story, sex worker are more sex is the exposure, and cervical cancer is the outcome. And the problem which they are doing is they are asking this history of more sex only from sex worker, which has other confounder also. So confounder is an external factor. Remember this 2-3 point about confounder which they keep asking in INICET exam. First thing is, confounder is unequal in two group. It's never equal, because nothing in the world is equal. So confounder will also be unequal in two group. Second thing is, confounder is related to both. It is related to exposure also and related to outcome also. Third point is that confounder and effect modifier also do not come in causal pathway. They don't come in causal pathway. Okay. What does it mean? They do not come in causal pathway. It means even without them, same thing can happen. They are not directly causing it. They are not coming in the causal pathway. And there is one more thing, effect modifier, which is only related to outcome, which is not related to exposure. That is effect modifier. Like we can explain it very simply. Suppose a boy proposed and a girl accepted. Let the love story should have a happy ending. So boy proposed and girl accepted is the thing. Now whenever we talk about those friends who only know girl, they don't know the boy, these are effect modifier, because they are only related to outcome. They are not related to exposure. So they are effect modifier. And if you look at the common friend, बीच वाले दोस्त जो दोनों को जानते हैं ना, then the common friend will be the confounder, because common friend is something which can make or break their relationship. It is related to exposure, outcome both, so it is the confounder. Now, what does it mean when I say they don't come in the causal pathway? Because we don't need common friend or girlfriend always. Sometime a random boy can propose a random girl and thing can happen. Or let's say talk about Tinder and all. Girl swiped, boy swiped. And is there any feedback? Is there any that this boy performed really well, 5-star performer like that? No. So all this thing of common friend or girlfriend, they are external factor, but they are not coming in the pathway. Even without them, same thing can happen. So they both don't come in the pathway and they both are unequally distributed. but only difference between them is effect modifier is only related to outcome and confounder is something which is related to both exposure and outcome. Okay, so I hope you will remember this part, and we will do some more question on confounder, effect modifier, then we will come and discuss this part. Now let's come to discuss this next very interesting question being asked 2 times already in NEET also and INICET also, that why we do direct standardization. What is the purpose of doing direct standardization? Can you reply, my dear friend? Is it the cause of death? Is it the denominator, age distribution, numerator? What is causing this? What is the reason of doing direct standardization? So let's say you are comparing the crude death rate of India with crude death rate of Japan. Crude death rate means, I hope you know, crude death rate simply means what is the total death out of 1,000 mid-year population. And what is the crude death rate of India? Out of 1,000 people, how many die in 1 year? In India, crude death rate is 7.2 per 1,000. But out of your 1,000 friend, how many will die? It will not be 7.2 because your age group is 15 to 20 or 20 to 25 or 25 to 30, young age. And in young age, in between 20 to 25, 25 to 30 and 30 to 35, in this age group, 2 death per 1,000 Indian. This 2 death per 1,000 Indian is known as age specific death rate. किसी भी 5 साल के एज ग्रुप में कितनी मौतें हुई हैं उसको कहते हैं एज स्पेसिफिक डेथ रेट. और इंडिया जैसी कंट्री में हमें पता है कि हर 5 साल के बीच के 1000 लोगों में से कितने मरेंगे. तो इंडिया जैसी जो पॉपुलेशन है, ऐसी पॉपुलेशन को हम कहते हैं स्टैंडर्डाइज्ड, है ना. कभी कभी हम लोग बात भी करते हैं ना कि ये बंदा स्टैंडर्ड बंदा है या ये बंदी स्टैंडर्ड बंदी है. क्या मतलब है? व्हेन आई से दिस बॉय स्टैंडर्ड और दिस गर्ल इज स्टैंडर्ड, व्हाट डज इट मीन? इट मींस वी नो समथिंग अबाउट देम, है ना. दे विल बी एजुकेटेड, दे विल बी टॉकिंग वेल, है ना. दे कैन नॉट से फार्ट, पॉटी, सिट in between, है ना. They are something predictable. That's why they are standardized. So because Indian population, we know in any 5 year how many will die. So Indian population is also standardized because we know about Indian. So they are standardized. But if we talk about street children or doctor population, they are non-standardized because we don't know in out of 1,000 doctors of 25 to 30 year, how many doctor die, we don't know. So doctors are non-standardized, but national data are standardized. So point is कि when they ask to compare crude death rate, we compare the crude death rate for all population, not for any 5-year age group. And in crude death rate, when do you measure the mid-year population? This mid-year population is measured on 1st of July. Okay. So crude death rate of India is 7.2 per 1,000 and crude death rate of Japan is 11.1 per 1,000. So if you compare the crude death rate, it looks like Japan should learn from India because in Japan out of 1,011 are dying, in India only 7 are dying. But is it the real picture? No. This is not the real picture. Actually, Japan has much better health system. So why Japan crude death rate is coming high? Because in Japan, more than 26% are above 65 years. They have more old age population. And in India, only 8% population is above 60 years. So India have more young age population. So because of this difference in age group, we cannot compare crude death rate. So what we should compare, if you really want to know whether health system of India is good or Japan is good, what you should compare is, you should compare the age specific death rate, age specific mortality rate of 0 to 60 year Indian with age specific mortality rate of 0 to 60 year Japanese. So if you compare the age specific mortality, means you are counting all the deaths which occur between 0 to 5, then 5 to 10, then 10 to 15. This 5-year comparison is age specific mortality. And you add all 0 to 60 combinedly. So then for India, it will come around 5 per 1,000. But for Japan, it will come around 2 per 1,000. Now this comparison is real, that India should learn from Japan, because India have age specific mortality 5, Japan has age specific mortality for 0 to 60 year only 2. इन 0 to 60 ईयर, 0 से 60 साल के बीच में भारत में 1000 में 5 मर रहे हैं, जापान में सिर्फ 2 मर रहे हैं. ये ज्यादा सही चीज बता रहा है. क्यों सही चीज बता रहा है? क्योंकि अब हमने बूढ़े लोगों की पॉपुलेशन को हटा दिया है, हम केवल 60 साल के नीचे को देख रहे हैं. Why this ASMR age specific mortality rate comparison is better? Because here we have removed all the old age people. We are just comparing the people between 0 to 60 in India and 0 to 60 in Japan, not talking about old age. So this is known as direct standardization. And we can do direct standardization between two big countries. Directly we can compare because they are big. So we can directly compare them. And why we need to do direct standardization? Because in some country people are more old age, in some country people are more young age. So due to this age difference, we have to compare them by direct standardization. So do remember what is the purpose of direct standardization? The purpose is there is difference of age distribution. Difference in age distribution is there. Some are young country, some are old country. So to remove this difference of age, we compare them through direct standardization by using their age specific mortality rate for any 5 year age group. Okay, so why we do direct standardization? For removing age distribution difference. Okay, chalo, next question is, if you want to compare two drugs in clinical trial, which epidemiological study cover the most accurate result? If you look at the evidence-based medicine, meta-analysis is having the strongest evidence. The strongest evidence is of meta-analysis, and expert opinion is having weakest evidence. What does it mean? It means do not trust on anything which I am telling you, because I am just an expert. I can be biased and I can manipulate you. Trust on my word only when my words are coming through some reference book like PARC or something, or through some study done already on that topic. So my point here is that this expert opinion is weakest evidence and meta-analysis is strongest evidence, because in meta-analysis we combine the data and theoretical result of many study done on one topic. So it becomes the strongest evidence. And then second importance evidence is of systematic review. Then the third in the sequence is RCT. RCT is third in sequence. Fourth is cohort study, prospective cohort. And then fifth is case control. Then there is cross-sectional and other thing. So the question here is, when you are comparing two drugs in clinical trial, which study is most accurate? So most accurate study can never be cohort or cross-sectional, because they are too low. Answer is either meta-analysis or RCT with double blind. The only problem in meta-analysis is that in meta-analysis we are combining many study, but we are not sure how those study are done. So if those study are bullshit, even when you combine them, the final study will also be bullshit. Are you understanding it? है ना, टट्टी में से कुछ भी निकालोगे, निकलेगा तो टट्टी ही ना, है ना. If you take out anything from latrine, it will be a latrine only. So if all the study taken in meta-analysis is done by a wrong way, by biased method, then your meta-analysis can also be poor. So we cannot trust on meta-analysis due to this problem that it can use wrong study in coming to a conclusion. And therefore the better option will be RCT, randomized control trial with double blinding. And because it is done with double blinding, so there is less chance that researcher can also manipulate the data, is very less chance, because double blinding means participant don't know whether they get drug or medicine, plus the researcher also don't know whether they are getting drug or medicine. And if both don't know, then chance of manipulation is less. So if they ask in evidence-based medicine which is the best, answer will be meta-analysis. But in this specific case, when they are comparing two drugs, it's better to compare it in front of your eyes by doing RCT and double blinding, rather than trusting on someone else's study. Okay, so here the answer is RCT with double blind. Next question is, in the WHO Road to Health chart, what are the upper and lower limit represent? Can you answer it? This is not a matlab a very, this is some area where students think they know and they miss. If you see in the WHO growth chart, they have asked this question already one more time also. What do you call these people who are between second and third line? Are they mild malnutrition or moderate or severe? So remember, all the people who are between first and third line, this first line is 50 percentile of weight of boy. Why we take weight of boy above? Because boys are generally born with bigger body weight. So upper cutoff is 50 percentile of weight of boy. And the second line is third percentile of weight of girl. Third percentile of weight of girl. So what does it mean? It means that all the children who are between this first and second line, they are either following road to health, that means they are healthy, or they have mild problem only. So road to health is between 50 percentile to third percentile. Now, mild and normal are there. There is nothing like mild malnutrition or mild pneumonia. It's directly moderate. So the people between second and third line, they are moderate malnutrition. And the people who are below third is severe malnutrition. So this third line is showing -3 Z score or -3 standard deviation. But what does third percentile line tell? This third percentile line tell -2 standard deviation. So this is a confusing area. Do focus here. My point is, usually we think third percentile is at -3 standard deviation, but no, third percentile is at -2 standard deviation. Why? Because suppose this is the 200 children which we have taken from different countries. These are the various children. Okay. In the WHO growth chart, we have used this line, the center line, 50 percentile line for boy, 50 percentile of boy. Then we know between -2 standard deviation and +2 standard deviation, 95% people lie between -2 to +2 standard deviation. So if 95% are inside, how many are outside? If you remove 95 from 100, only 5 is left. And that 5% cannot go on one side. So 2.5 will be this side, 2.5 will be this side. So how many children are below -2 standard deviation? 2.5. And can you have 2 and 0.5 children? You cannot cut them into half and 2 and 0.5. So we can say that below -2, roughly 3% children are there. That is why third percentile means not -3 standard deviation. Third percentile means -2 standard deviation. Because below -2, only 2.5 or 3% people are there. So remember, third percentile is the lower line, which is at -2 standard deviation. And between second and third line, there is moderate malnutrition. So what is the road to health chart? Upper limit is 50 percentile for boy and third percentile for girl. This is upper limit 50 and lower limit third percentile for girl. Why? Because boy children have more weight, girl child have less weight. But girl child has more tensile or strength from inside. If two children are born with 1.5 kg weight, one is boy, one is girl, then girl has higher chance of survival. They survive more, but they are born with lesser body weight. So this is the road to health chart. I hope you will remember. This WHO growth chart is initially something which India don't used to follow because it was made on American children standard. So then WHO took children from 6 countries, in which India was also one country, and prepare one more growth chart, which is known as multi-centric growth research study WHO chart. So this WHO chart is which chart? MGRS chart, multi-centric growth research study. Second point in growth chart you should know is that suppose I took my girl child Prisha Lakshmi to you and you made her wait for age you measured, and in my family everyone is like this only, and C came here, suppose above this upper line. What will you call this patient? Is it a normal person or a obese? What will you call it? Don't you dare to call it obese. Okay, I'm not talking about me, है ना? किसकी बात करी मैंने? This is my girl child I'm talking. C is perfectly normal. Not because my girl child, so you have to say normal. No, fourth here. If you got just 60% in your percentile in your NEET exam, are you a topper? No, 60 percentile doesn't mean you are a topper. For being a topper, you need 99 percentile. So if a child is just above 50 percentile, it's also normal. To be abnormal, you can be somewhere here, this much high. Then you can be abnormal. Okay. So do remember MGRS chart, which we use in India. Start with 50 percentile, and then second line is third percentile. Between them, we have healthy children, road to health. And this is MGRS based study. One more thing which I discussed there was that when I say percentile, this was one of the recent INICET question, that percentile or position, that means quartile or outlier. Percentile, quartile and outlier. What do these things tell? Percentile, quartile, outlier tell about. What do they tell about? Do they tell about central tendency? Do they tell about measure of dispersion? Or do they tell about position or location of data? So if you are getting 99 percentile, okay, it means you are having the topmost position. So this 99 percentile is telling your position. Quartile means you are at 25%. This is also telling your position. And outlier means extreme value. And like this is extreme value. And this box and whisker plot, which is between 25% to 75%, this is used to tell about the extreme value, which are outlier. So what are outlier? Extreme value. And box and whisker plot help us to find outlier. This is the purpose of box and whisker plot, to tell outlier. What is outlier? Let me tell you a very simple example. In every 2 to 3 years in UK, they do a survey that how many sexual partner you have lifelong. And usual answer which comes is 2 to 7. But in the same UK population, some hunter give this data 699 sexual partner, 599 sexual partner. So should we include those hunter data in normal population? No, because if we include that big data, the whole population will get depressed. They will think that all are doing, we are not good doing, because average will shift very high if we will include those high number. So we remove those hunter data by calling them outlier. So outlier is also telling position. Percentile and quartile also tell your position. So position or location is told by this thing. Central tendency is by mean, median, mode, out of which mean is used for quantitative data and median and mode are used for qualitative data. And now whenever we apply chi-square test for qualitative data, median and mode are the method by which we express qualitative categorical data. And measure of dispersion are 5 things: range, mean deviation, standard deviation, variance, and standard error. These 5 things tell about measure of dispersion, how much spread is the data. So I hope you will remember that all these questions on quartiles and outliers and WHO growth chart. Now let's come to the next question. Common to both acute and chronic malnutrition, which is common to both. So do remember one thing for sure. Whenever we compare weight for height, this is very frequently asked question. Weight for height, if it is low weight for height means the ऐसा समझ लो कि बंदा लंबा है और सूखा हुआ है. आपका कोई ना कोई दोस्त ऐसा होगा जो बहुत लंबा है और बहुत सूखा हुआ है. तो इसका लंबा होने का मतलब है बचपन से अच्छा खाया है, क्रॉनिक प्रॉब्लम नहीं है, अभी ब्रेकअप हुआ है इसलिए बंदा नहीं खा पा रहा है. तो जब भी हाइट अच्छी हो, वेट कम, बंदा सूख गया, वेस्टिंग हो गया. और वेस्टिंग का सीधा मतलब है कि बचपन से अच्छा मिला है, यानी क्रॉनिक प्रॉब्लम नहीं है. प्रॉब्लम कैसा है? एक्यूट मालन्यूट्रिशन. What I was saying in Hindi was that you must have one friend in your group which is very tall and very thin. That friend, you can say कि he is wasted. And if he is tall, it means the problem is not from childhood. The problem is not chronic. Problem is acute. In last 1 month due to breakup, he is not eating, or 6 months he is not eating. So this type of acute malnutrition is causing wasting. So remember, weight for height is wasting. And if weight for height is less than -3 standard deviation, weight for height less than -3, then we call it severe acute malnutrition, SAM. SAM has 3 criteria. First criteria, weight for height less than -3 standard deviation, not -2, -3. Second criteria, mid-arm circumference should be less than 11.5 centimeter. This less than 11.5 is red color and on Sakir tape. And third criteria is there should be visible wasting or edema. So if you found this three thing, then the child is severe acute malnutrition, SAM child. So weight for height is only telling acute, not chronic. And if someone height for age is low, low height for age means stunting. And if someone is low height for age, it can be due to familial short-heightedness or it can be due to chronic problem. So we all know height for age low is a chronic problem. So height for age only tell chronic, weight for height is telling wasting acute, and weight for age is telling both acute and chronic. That is why if they ask in Anganwadi which growth chart is drawn, so in Anganwadi the growth chart is weight for age, because this tell about both acute and chronic problem. Second question which they ask from here is up to which age children go to in Anganwadi, up to 3 year, 4 year, 5 year, 6 year. Answer is age is up to 6 year children go to Anganwadi. And nowadays government has done a new thing. They are trying to shift or attach all Anganwadi with government school. So gradually Anganwadi and government school will be working together so that there is no dropout. Because in some time children do Anganwadi but then they don't go to school. So if they connect it, chance of dropout will be less. So this is a newer initiative of Government of India to mix Anganwadi with a school, do remember. And in that question, what is the answer? Of course, weight for age, because it tell both. That's why we use it in Anganwadi. Now, this acute flaccid paralysis, I hope you know, can be due to 4 reasons. One reason is transverse myelitis. Second reason is traumatic neuritis. Third reason is Guillain-Barré syndrome, which also occur with Zika virus infection. And the fourth reason is polio. So even if polio is not occurring, at least due to these other 3 reasons, some child will have flaccid paralysis of lower limb. And this is regularly surveyed, that how many people are having flaccid paralysis. Because if we stop surveying for flaccid paralysis, we can miss some case of polio. So this AFP surveillance is still going on in India, and minimum reporting of AFP, minimum acute flaccid paralysis should be 1 per lakh. 1 per lakh. देखो अगर पोलियो नहीं भी हो रहा है तो बाकी कारणों के चलते कम से कम 1 लाख में 1 लोगों को तो पैरालिसिस होगी ही होगी. Even if polio is not occurring due to other reason, at least 1 per lakh will have paralysis. So this minimum AFP is known as baseline rate of reporting. This is baseline reporting rate of polio. Okay? And whenever someone report it, so they get some money from the government. That is why the same case is sometimes reported by doctor, sometimes reported by MPW. Different people report the same case to get more money. So that's why what we do, Government of India do, is line listing. Why we are doing line listing means we are writing the cases and we are avoiding any duplication. So purpose of line listing is to remove duplicate entry, to remove duplication. Then the third point is you went to the home where there is paralysis. First thing you will do is you will do mop-up vaccination. Mop-up vaccination means if one child is found to have polio, it means there is 999 child in the area which also have polio. So you will try to give OPV to all the children in those area below 15 years of age. This is known as mop-up, because if water fall in some place, we don't mop up just that area, we mop up the whole surrounding. So similarly here we have mop-up vaccination, which is done for all children below 15 years in that area. After doing mop-up vaccination, you go to the home of the child who have paralysis and you will collect 8 grams of stool. You will not measure it by some weighing scale. If it is half of this thumb, we call it 8 grams. And this 8 gram stool will be taken to WHO lab from village. This is known as reverse cold chain. In cold chain, we send the vaccine from state to district and district to village. And in reverse cold chain, we are sending the stool sample from village to district to state. So it's in a reverse direction. And of course, we are maintaining the 2 to 8 degrees Celsius, so it is cold chain also. Now, after sending it, the WHO lab will confirm it and all. And sometimes the sample we send, but it do not reach in good condition till the lab. So even if polio bacteria virus is there, we are unable to detect it some cases. So what we do, after 60 days, we do a revisit, re-evaluation of the case. And after 60 days also, if there is the same amount of paralysis, it means polio confirmed. If on re-evaluation you again find polio, it means it is polio. Because if the paralysis is due to transverse myelitis, traumatic neuritis, or GBS, they will either improve in symptom or the patient will die. But they will not remain same. But in polio, you know, if it happened once, it will remain same. So after 60 days, you found polio, it means polio confirmed. And so if you found paralysis after 60 days, polio is confirmed. This is known as the residual paralysis should not be there after 60 days, because other cases recover in 60 days, but not polio. So this is everything, every story of polio that they have asked in INICET exam. They have asked baseline reporting 1 per lakh. They have asked line listing to prevent duplication. And they have asked this thing, that how many times we do the revisit after 60 days. Now let's look at one more question here. The question is, they are saying that consumption of vegetable, if you will increase consuming vegetable, this vegetable is containing beta carotene. So because it contains beta carotene and you are consuming vegetable, therefore there is less chance of cancer. Cancer will decrease. Okay. But when they were talking about vegetable and cancer, they say that in the vegetable there is also a lot of fiber. Vegetable have fiber. And if you consume fiber a lot, there will be less constipation. So there is less chance of colon cancer. So they are asking, this story is an example of which thing? Basically, they are asking in this story, what is this fiber? So this fiber, you can see, is related to exposure also. And fiber is related to outcome also, colon cancer. And we already have discussed that if something is related to exposure and outcome both, we call it a confounder. So what is fiber here? Confounder factor. But suppose in the same story, if I insert water, so we all know water, if you will increase 4 liters per day water, if anyone will drink, there is no chance of constipation that will remain. Main reason of constipation in medical student also is we skip our breakfast and we don't drink 4 liters water because of we are skipping breakfast. So don't skip breakfast, take 4 liters, no constipation will be there. And all your hair which are white, they will also turn black. My hair were white in MBBS day due to constipation. And when I start taking breakfast and 4 liters water every day, the white hair also turned black. So do focus on 4 liters water, something which is very good for your inner health. Intestine will bless you if you take 4 liters water. So my point is that if you take more water, 4 liters, colon cancer will be less. But water is not directly related to vegetable. But water is related to outcome, colon cancer. So what is water here? Confounder or effect modifier? Yes, you are right. Water is effect modifier. Because water is something which is related to outcome but not related to exposure. It's like only girlfriend who know only the girl, not the boy. So that's effect modifier. So here, what is this fiber? This is confounding factor. So next question. Which of the following is true for incubation period? That was the question in last year NEET exam. That maximum incubation period is the duration of which thing? Maximum incubation period is the period of quarantine. So we use incubation period for quarantine. But what do we use for isolation? For isolation, we use period of infectivity. देखो ये बड़ा ही आसान है समझना. We can understand it with a common simple example. Suppose Nikhil have a girlfriend in Netherlands, New Zealand, okay? And Nikhil went there to meet the girlfriend. But at the airport, there was a lady doctor. He looked at Nikhil from head to toe and he said, "Ki you are carrying a lethal virus in you of chicken pox. So now Nikhil is healthy and quarantine is done on healthy people. Till which time Nikhil will be kept in New Zealand airport? Till the maximum time of appearance of symptom pass away. And this is known as incubation period. Entry and appearance of symptom, that the gap between them is incubation period. मेरे अंदर कीड़ा घुसा और मुझे खांसी आई, इसके बीच का गैप ही तो incubation period है ना. First symptom and entry, the gap is incubation period. So Nikhil will be kept in New Zealand airport till 21 day, because for chicken pox incubation period is 10 to 21 day. So you will isolate for you will quarantine for 10 day or 21 day. You will quarantine for 21 day. So for 21 day Nikhil will remain there. Now when Nikhil is about to come out, suddenly one vesicle came out from the body of Nikhil. Which part, that I don't know, but some part vesicle came out. So now Nikhil is having the disease. Now he will be isolated. Till which time? Till he can infect other, he will be isolated. And in case of chicken pox, this isolation period is 6 days. So for 6 more days, Nikhil will be at the airport, but don't worry about Nikhil. In that 21 day, he did setting with the lady doctor there. And now they will enjoy their remaining 6 days by rubbing their vesicles together and all. So this is 6 days when it is isolation. Because isolation is done on diseased person. Isolation was done on Nikhil when Nikhil was already suffering from some illness. So isolation is done done on diseased people. Quarantine is done on healthy people. And remember, incubation period is not for isolation. Incubation period is for quarantine. So wrong answer is, which of the following is not true? Isolation is not done till incubation. That is not true. Isolation is done till period of infectivity. Now let's look at other two options also. To differentiate between secondary attack rate and coincidence of primary case. Yes, because do remember, number of cases affected in one incubation period. This is not primary attack rate, this is secondary attack rate. Because first some person had got infected. Now within next 10 to 14 days, in case of measles, next 10 to 14 days, some more will get infected. So those people who are infected in second round, they are infected within one incubation period. And they are known as secondary attack rate. So yes, they are right. We use incubation period to find secondary attack rate. And number of people infected in one incubation period is not primary attack rate. This is secondary attack rate. Okay. So we can use incubation period in secondary attack rate. We can use incubation period to prevent disease in contact. Yes, because even if they are healthy, they are quarantined. So it can help preventing disease in the contact by doing quarantine. And a quarantine we do of healthy contacts. So yes, all the options are correct except isolation, because it depends on infectivity. Natural disaster causing maximum death is definitely hydrological or flood. And in hydrological, which disease is most common? Gastroenteritis is most common. Other than gastroenteritis, the second disease which causes death is leptospirosis. And actually this is the most common disease which occur in Kerala flood and Mumbai flood. So when leptospirosis occur, the government distributed diethyl carbamazepine to all the people of Kerala area so that they are protected from leptospirosis. This is known as chemoprophylaxis. But along with diethyl carbamazepine, how does leptospirosis spread? I hope you know. चूहे के मूत से, है ना, with rat urine it gets spread. So in leptospirosis life cycle, which has been asked in INICET already, you will find rat urine. So along with DEC, we also need to give a rat killer to these people. And what is the rat killer? Malathion or zinc phosphide? Malathion kill mosquito. Rat killer is zinc phosphide. But one very good app, they wrongly answer it malathion. Why it is wrong? For sure, because malathion kill mosquito and here we need to kill rat. So correct answer is rodenticide zinc phosphide, which we will give with DEC. Okay, that was one question based on it. What other than DEC we give? We give zinc phosphide, not malathion. Please try to understand it with logic. Second thing is, if you still have doubt, you can always message me for any of the question, any of the controversy, any of the area which you are unable to understand. You can always WhatsApp me, or you can ask it on PW MedEd Telegram group, Sankalp group. You can ask the question there also. Okay. So now Hydrological is most common, gastroenteritis, then there will be leptospirosis, then there will be cholera. Third common thing. Fourth common thing is rickettsial disease. Because whenever people live together in cold and swampy areas or where water is there also, then small insect grow there and they transmit rickettsial disease. So you can say these four are the most common, out of which gastroenteritis is actually the most common disease. Other than this, mosquito transmitted disease can also occur, but these are more common. Okay, so remember, flood is most common and gastroenteritis is most common disease. Now, if like in one of the class, a student asked me this question, ki sir, why gastroenteritis is most common in Bihar and Assam when leptospirosis is actually common in Kerala and Mumbai? It's because in Bihar, Assam, the health system is also in very poor condition. So when they are unable to make diagnosis, they label it as gastroenteritis. And in Kerala and in some part of Mumbai, the health part is good. So they know it is leptospirosis and therefore they can treat specifically. Okay, so let's come to answer this question. Which type of study is it? They are saying that investigator obtained an increased incidence of disease. So if you go by word, incidence or new case is something which we detect in cohort study. Incidence study is known as cohort study. But cohort study is something which is done on individual. You collect data from people who are exposed, having some risk factor present, and non-exposed, having no risk factor or risk factor absent. So when you collect new cases in exposed, non-exposed in future, that is cohort study. But let's see what they are saying here. They are saying that they collected a data that due to low fiber diet in a country, the cases are increasing, and they get the data from food industry of the country. So this is not coming from individual. This is coming from population. So population is giving the data that fiber diet is getting less, junk food is increasing, and this incidence of disease is increasing. This we collect in cohort study. But this new case of disease is also collected by hospital data. And here we are correlating hospital with population data. Here we are not saying that there are two groups. One group is having some disease, one group not having, one group eating low fiber, one group eating high fiber, and then they are followed in future for disease. No, we are just saying that this data has been found that more disease are there and less fiber intake is there. So it is just population and hospital data which they are correlating. So it is again ecological study. But if you want to make it a cohort study or a prospective cohort study, then cohort study, how they will make the story? In cohort study, the story will be that in a study it was found that there were two groups of people, one group who are eating high fiber, one group who are eating low fiber, and then in future it was found that the group which were eating high fiber have less disease, low fiber has more disease. So if there is two group, only then we go for cohort and case control. If there is one group, one population, like in this question, then answer is mostly cross-sectional or ecological. And then how can you differentiate between cross-sectional and ecological? Very simple. In cross-sectional, we ask question about prevalence from everyone. Like if I ask from everyone, do you have cold and cough? From everyone I am asking, I will know the prevalence of cold and cough 10 out of 100. So that's why cross-sectional study is prevalence study, and in cross-sectional, we ask it from everyone. But in ecological is also one unit, one population, one group. But we don't ask questions from individual, we take it from population. That is the difference between cross-sectional and ecological. They both are having one group, but cross-sectional question from everyone, ecological question from population. So do remember it. Now let's do some numerical question. This question, I have discussed it in one of the guest paper, and the exact data came. With this exact data, the question also came. The question is based on your knowledge of stillbirth, low and early neonatal death and all those things. So if you look at PARC say that any child who died between 28-week period of gestation and birth, this child is stillbirth. But if you look at the WHO data, WHO say it is not 28 week, it is 22 week till birth, any death is stillbirth. So I would recommend to follow Indian data, because in India, after 28 week till birth, we call it stillbirth. Then after birth, in the first 7 days, if someone die, we call it early neonatal. And if you mix these two things, early neonatal and stillbirth, from 28 week till first 7, this is known as perinatal. पेरी का मतलब है चारों तरफ, natal का मतलब है birth. Birth से पहले भी बाद भी, because it is before birth and after birth also, so we call it perinatal. Peri means around birth. So this is perinatal. And if they ask what is the best indicator of female condition of the country, answer is perinatal death rate. Because if female is not good, stillbirth or premature delivery will occur, and they will count in perinatal. So do remember perinatal, best indicator of female health. Okay, best indicator of female health. Why not best indicator of female health is maternal mortality? Because even if female health is very poor, she will not die. So maternal mortality do not tell about female health good, and she can survive there. But if children are dying, it means mother were malnourished. So mother health is best told by perinatal death. Now between 7 day to 28 day, if anyone die, we call it late neonatal. And this total period of 28 days since birth is known as neonatal. Birth till 28 day is neonatal. Okay, neonatal period. And anyone who die between 28 day till 1 year, this is, many class the students say this is infant death. No, 28 day till 1 year is post neonatal. And if you add post neonatal plus neonatal, post neonatal plus late neonatal plus early neonatal, if you add all this thing, three things, then it become infant death. Because in infant death, you have only those who are birth to first year. So this question also has been asked, which is not included in infant death. So infant death do not include stillbirth. Infant death do not include complete part of perinatal mortality. So perinatal mortality and stillbirth, they are not completely included in infant death. Okay, do remember these two are not included. Now why I write all this part together? Because if you want to know formula of any one of the following, you just need to remember the duration within which those deaths are occurring. The denominator of all this formula is always total live birth, and it is always multiplied by 1000. So multiplication factor and live birth remain same in all this formula. What thing differ? Only thing is the numerator that differ. Like, let me explain this thing. In this question, they are asking neonatal mortality. So neonatal means first 7 day, 0 to 7 plus 7 to 28 day. You just added the duration. This 0 to 7, 7 to 28 is neonatal. Remaining part remains same. So every definition we can remember, denominator is always live birth multiplied by 1000, only numerator changes. Now let's look at the question. First they are saying that out of 4050, 50 is stillbirth. So what is the live birth? Live birth is 4050 minus 50, because they already died before taking birth. Then they said 50 infant died within 7 days, whereas 150 died within first 7 to 28 day. So total 0 to 7 day death was 150, and 7 to 28 death was 50, and we multiply by 1000. So if you add 150 plus 50, it is 200, and 150 plus 50 is 200, and divided by 4000, multiplied by 1000. So this 0 will cancel out, and 4 will cut 200 by 50. So neonatal mortality will come 50. Sometime in the same question, rather than asking neonatal, they ask perinatal mortality. And usually the answer of perinatal also come 50. Why? Because they give stillbirth is also 50. And early neonatal, stillbirth plus early neonatal is perinatal. Stillbirth is 50, early neonatal is 150. So again, if you add 150 and 50, it will be 200. And 200 by 4000 into 1000 will again be 50. So whether they ask neonatal or perinatal, do remember in both the case, answer is same 50 here. So I hope you will understand this whole definition, and this type of numerical you can easily do. Now let's come to the next question. The next question is, what is true about oral polio vaccine except? We get quick immune response, yes. With OPV, we get quick immune response because it multiply in intestine and give immunity much quickly. IPV give immunity late. That is why, which thing we use in epidemic? OPV, because it give immunity quickly, plus OPV you give in the intestine and then through fecal-oral route it can transmit. So in epidemic, OPV is useful. It is a live vaccine, yes. Maternal antibody interfere with immune response? No. Maternal antibody interfere with immune response in measles. In measles, if you give injection of measles in first 6 months, measles virus is also live and maternal antibody will fight with the in vaccine thinking it is the virus. So have you heard anywhere that measles is given in first 6 months? No. Why? Because in the first 6 months, if you give measles vaccine, the mother antibody, IgA antibody, which is coming through the breast milk, they will make this vaccine ineffective. माँ के एंटीबॉडी मीजल्स के वैक्सीन से लड़ जाएंगे और उनको इम्यूनिटी लाने ही नहीं देंगे. तो मैटरनल एंटीबॉडी मीजल्स के खिलाफ काम करते हैं, पोलियो के खिलाफ नहीं काम करते. तो not all except maternal antibody do not work with measles. Now let's come to understand measles part better. During epidemic, when will you give measles? If suppose there is an epidemic, when will you give measles? At 9 months or 6 months? If it is epidemic already present, measles we give at 6 months, not at 9 months. 6 months we give. Then what about the 9th month dose? Do you keep giving it? Answer is yes, continue without any problem. Because if you give the vaccine at 6 months, we give it to control epidemic. But we think at 6 months it's not so effective because maternal antibody will fight with it and make it useless. So we still give the second dose at 9 months. Okay. So yes, we give it at 6 months, but we continue giving it at 9 months. So this work, a maternal antibody work for measles, not for OPV. Now, next question. If the prevalence is very low as compared to incidence for a disease, what does it imply? This is the question basically which is coming from this formula, that prevalence is equal to incidence into duration of disease. What is incidence? New cases. Duration means the timing for which the disease remains. So they are saying prevalence is very low, incidence is high. What is happening? Incidence is high, prevalence is low. What does it implies? Like, let me give you a very good example. Example is of cough cold. If I ask right now, in your class of 100 students, how many have cough cold? I know hardly 10 will have cough cold out of 100 right now. So prevalence is only 10 out of 100. But if I ask in next 1 year, how many new case of cough cold will come? How many new case out of 100? Of course, everyone will develop cough and cold in 1 year, and incidence is measured in 1 year. So it can be 95 out of 100. So you can see incidence is high, 95, and prevalence is low. For which disease? For cough and cold. Why prevalence is low, incidence is high? Because cough and cold only stay for 2-3 days. Because duration is low. So when you multiply low duration with high incidence, final result also come low. So what does it mean? It means whenever you have low prevalence, high incidence, it means disease is very fatal or easily curable. Here we give the example of easily curable, that because it is cough and cold, within 2-3 days it goes away. So prevalence is low and incidence is high. But same thing can also occur with Ebola. Ebola have case fatality rate of 50 to 80%. That means if 100 people will develop Ebola, in next 7 days, out of 150, 80 will die. So we start with, let's say, 100 new case. But at the end of 1 week, how many is the prevalence? Only 20 to 30%, 20 to 50% maximum. So 50 is here, 100 was here. It means prevalence is low, incidence is high. Why? Because Ebola kill you quickly, duration of disease is less. So remember, whenever disease is very fatal or easily curable like flu and very fatal like Ebola. if you are doing any study on disease like Ebola and flu, which are for very short duration, then prevalence will be low, incidence will be high, and this bias is known as Niemann bias. The other name of Niemann bias is high incidence, low prevalence bias. High incidence, low prevalence. See, if you are trying to do any study on Ebola or flu, if you start with 100 people, within next week, out of your 100, either 50-80% will die or 50-80% will get cured by themselves. So at the end, there is very less people to do your study on, and therefore result will come wrong. So this bias of wrong result is known as Niemann bias. The other name of Niemann bias is high incidence, low prevalence bias, and it occurs only when the disease is of short duration like Ebola or flu. Okay, so I hope it is clear. If not, feel free to ask it on the number which I have shared with you or on MedEd Sankalp group. Next question is that for an RCT to assess dating in adolescent, now a topic which interests us. A study was done by selecting random school, then random classes, then random section, then random student. I want to know how many student is dating in class 11th and 12th out of Delhi. And so suppose this is the map of Delhi, draw amoeba and it will become Delhi. So from the Delhi, I choose 3 area. From each area, I choose 2 colony. From each colony, I choose 4 school. And from each school, I choose 20 student, 10 boy, 10 girl. So what I am doing is, I am choosing cluster again and again. So this is known as multiple cluster sampling, because Delhi is a cluster of people and colony is also cluster, school is also cluster. So we are choosing cluster again and again. This is multiple cluster sampling. And other name of multiple cluster sampling is multi-stage sampling. So multi-stage or multiple cluster means they will give you an image-based question from here. That's why I draw the image of Delhi. And then from the image, they will ask area, colony and all small thing is chosen. Which type of sampling? That is multi-stage, multi-cluster sampling. And finally, how many students we did the study? 20 student, 4 school, 2 colony, 3 area. So 6 plus 4, 6 into 4, 24 into 20. 24 into 2 is 48, 480 student. You will do the study on 480 and you will say this is the data for whole Delhi, that in this 480 student, if prevalence of dating came 20%, you will say 20% of 11th, 12th class student are dating. So this is the way of multi-stage sampling, and this is the only way when you can get the data about whole Delhi. You cannot ask it from every student. So this is the best way. In US, UK also, this is the way they use to collect national data, multi-stage sampling. Now, these days, a lot of questions are coming on stratified sampling. So let me explain stratified simple cluster all to you very simply. Suppose I want to take 10 students for a party after the class. And in that party, I want, because I am happily married, settled type of person, I want more love in you people. So I want that in that party, there should be 5 boy, 5 girl. So first thing which I did was simple random sampling. I will get 10 people and it's the best sampling. If you are homogeneous, same to each other, then simple random sampling is best. I can choose 10. But the problem with simple random is, because it is done by lottery method, out of 10, I can have 8 boy, 2 girl, or I can have 9 girl, 1 boy. I want 5 boy, 5 girl, equal. So to get equal people, first we have to divide you into boy and girl and then choose 5 randomly. So this is a stratified sampling, when you divide and choose. So do remember, this question come again and again. The question is, if researcher or the person who is doing the study divide population and then choose, this type of sampling is known as stratified, because division means creating strata, creating layer. So this is the stratified random sampling. Do remember, very common question. There was one question on this topic. Try to answer it. Is it cluster or stratified? They said that out of 100 drug, researcher divided the drug into plant origin, animal origin, fungal origin. plant, animal, or fungal. So is it cluster sampling or is it stratified sampling? So researcher is dividing them. Because you are dividing them, this will be example of stratified sampling. Because you are dividing and then collecting the data stratified. So do remember, whenever you divide population, you can divide them based on their diet, vegetarian, non-vegetarian, based on their religion, you can divide them, based on their sex, you can divide them, based on the origin, you can divide them. If you are dividing them due to any reason, and you are dividing and choosing equal, is stratified. But what is cluster random? Cluster random means you are not dividing them. They are already living separately and you just choose some cluster or group of people equally. Like for example, if you want to know which have more lesser immunization, Bihar or Uganda. So WHO immunization studies say that we always have to choose 7 children of 12 to 23 months from 30 village. So all these 7 children are already living separately in different villages. You have not divided them. They are already living in cluster. And you choose the cluster of 7 children from 30 village. That means total 210 sample size. So this will be cluster random when they are divided themselves. Like for example, if I choose 5 boy for party from boy hostel and 5 boy for party from girls hostel, that is cluster random. Because now I am not dividing into boy and girl. You already are living in boy and girls hostel. So if I choose from boy and girl hostel, that is cluster. But in a class, if I divide you and then choose 5, 5, that is stratified. So do remember this difference. And do remember, if they give an image-based question with one state and then a small taken from it, that is multi-stage sampling. Okay, so I hope this sampling you will remember. Now, let's come to next question. The next question is, in a pattern of change of disease is occurring, previously we have more death due to communicable maternal neonatal nutritional disease. And this is CMNND death, communicable maternal neonatal nutritional disease death. This was more earlier. Now what is happening? Now the death is more due to NCD, non-communicable disease like cardiovascular disease is the more death, CVD plus accident. This is causing more death plus accident death. So previously our communicable disease death was more, now CVD death is more. What we call it? This is known as epidemiological transition ratio, ETR. So do remember, ETR, if ETR is high, it's a good thing or a bad thing? If ETR is high, it means communicable disease is still common in those areas. It's a very bad thing. For example, Bihar have high ITR of 0.74. Actually, I also come from Bihar, and when in writing they used to ask, where are you from? We used to say, I am from United States of Bihar. Very much similar to USA. So do remember, Bihar have maximum communicable disease burden. So epidemiological transition ratio is high in Bihar. And Kerala, on the other end, have very less communicable disease. Most of the deaths are due to CVD or accident. So Kerala epidemiological transition ratio is only 0.16. So Kerala have low epidemiological transition ratio. Bihar have high epidemiological transition ratio. And epidemiological transition ratio is high. It means communicable disease is more. So it's not a good thing. It's a bad thing if epidemiological transition ratio is high. Do remember, numerator is communicable disease. Denominator is CVD. Okay. So transition means from communicable to CVD, from numerator to denominator. Chalo. Now, next question is ki, when we don't do mass chemoprophylaxis, when we don't give medicine to everyone. So in case of lymphatic filariasis, we do it. What are the drug which we give for mass chemoprophylaxis? DEC plus albendazole. By these two drugs, we do mass chemoprophylaxis for lymphatic filariasis. For scabies, again, we do mass chemoprophylaxis by permethrin 5%, which is the drug of choice. If one person have it, we give it in the whole family. For plague also, we give mass chemoprophylaxis. I don't remember the exact drug, but I think it is by tetracycline, but I don't remember the drug exactly. But in vitamin A deficiency, we do not do mass chemoprophylaxis because we give it only till 5 years of age. So we cannot give it to everyone in the community. And do remember, when do we call vitamin A disease as a public health problem? They this ask. When you will call vitamin A is a public health problem? If in school going children, if in 6 month to 6 year children, night blindness is more than 1% and Bitot spot is more than 0.5%, then we call it as public health problem. Do remember 1% and 0.5%. How will you remember it? Very simple. Night blindness is a symptom. Patient come and tell about it. So it is easy to found 1%. But Bitot spot is the first screening test. Bitot spot is the second sign. First sign is conjunctival cirrhosis, dryness of conjunctiva, which look like sand on tide appearance. So first sign, they ask very commonly, first sign of vitamin A deficiency is dryness of conjunctiva, conjunctival cirrhosis. और एक टाइम एक डॉक्टर था जिसके अंदर एक पोएट की आत्मा थी, उसने ऐसा डिस्क्राइब किया कि ऐसा लगता है जैसे सागर की लहरों पर रेत की एक परत हो. वाह वाह वाह, है ना. See the beauty in the eye of beholder. Why they call it sand on tide appearance? Because due to vitamin A deficiency, there is gerophthalmia, dryness of eye. So tear is secreted less, and when the tear is less, the dust particle can deposit in the eye. So there will be some dust, some tear, some dust, some tear. It will look like sand on tide, and that's why they call it sand on tide appearance, conjunctival cirrhosis. And it is the first sign, but we don't use it for screening, because to see conjunctival cirrhosis, you have to go deep into the eye and see it, which you cannot do in the village area. So how we do screening in village area? Bitot spot, which can be seen from outside, is used for screening, not the first sign conjunctival cirrhosis. And do remember, Bitot is the second alphabet, A, B. Therefore, it is 1/2, half. A, B, 1/2, half. So Bitot spot is half, 0.5%. Then we call it as the public health problem. Night blindness, 1%. And we don't give prophylaxis for vitamin A. Some in WHO guideline, mass chemoprophylaxis is also not for cholera. When cholera is there, mass chemoprophylaxis by doxycycline is not so useful. So WHO say also don't give it for cholera. So for cholera vitamin A, we don't do mass chemoprophylaxis. Do remember. Chalo, next question. District population is 10 lakh with under 16, 13%, 30%. So 30% of 10 lakh. What is 30% of 10 lakh? 10% of 10 lakh is 1 lakh. So it's very simple. 30% of 10 lakh is 3 lakh. So 3 lakh are under 16. But they are saying that out of under 16, 3 lakh, blindness is 0.8 per 1,000. So 0.8 blindness occur out of 1,000 population. And here, how much is the population? 3 lakh. 3 lakh means 3 pay 50. Lakh always means 50. So they are asking, what is the number of blind people? So it's quite obvious. In 1,000 people, 0.8. So in 3 lakh, how many is the total burden? To calculate it, you just have to remove the 0. And 30 will be removed from here. So it is 300 into 0.8. Or you can simply write it 8 into 30. And 8 into 30 is 240. So these all numericals, you need not to scared. Many a time they are not so tough. And this is a PYQ numerical. Sometimes they copy it with the same data also. So don't be scared. When you get such numerical, you can easily do it. And just be patient and try to keep thinking on this in the right way without much emergency, and you can do most of the numerical. Like, let's come here. What is the current percent of Indian GDP spent on health? That is 1.2. But what is the WHO criteria which they have asked? WHO asked us to expend 5% GDP on health. But for last 35 years, whether it's Congress or BJP, does not matter. They are spending only 1% GDP on health. And we all know, no money, no honey. So this is one of the reasons of our poor health system, because money is not given. And then patient come and they abuse doctor that you are the reason why facility is not there. But the main reason is the government, which is still we support. They don't give money to health. and we are getting affected, patients are dying on referral, but we still have some intelligent people among us who support such government. And so that's why I request you not to support any government, because they are there just to come back in power. They are not there to help you. And if you will stop supporting government, or you stop being anti to them, you can stop wasting time on news channels, news things and all. And news only make you feel scared. So if you will not watch news, you can give more time on your growth rather than looking at the world. So this is my request, best strategy for INICET. Remove all those news things subscription. Even on Instagram, there are news which come after every 5-6. So this is way to make you feel scared. If you want to be scared in your life, have that anxiety and palpitation all the time in your life, keep watching news, and they will keep you scared. That's their main purpose. Now let's focus here. What the question is, what is the most common cause of neonatal mortality? Most common cause is premature delivery, and we call it premature delivery if it is less than 37-week period of gestation. Then we call it premature delivery. This is the most common cause of neonatal death also, most common cause of infant death also, and most common under 5 mortality also. Because in all this neonatal, IMR and under 5 mortality, the denominator is live birth. Live birth is used as denominator. But they ask this question, which indicator do not have live birth as denominator? So remember, child death rate, this do not have live birth as denominator. Because what is child death rate? Child death rate is the death of children between 1 to 4 years. That means roughly up to 5 years. And population between 1 to 4 years. And then we multiply by 1000. So in child death rate, live birth not a denominator. Live birth is not a denominator. And if somebody asks what is the most common cause of child death rate, then child death rate is not due to prematurity, because child death rate are counting those children which died after 1 year. So here the answer is not prematurity. Here for child death rate, answer can be pneumonia, answer can be sepsis or diarrheal disease, malnutrition and all. So for child death rate, most common will be pneumonia. But for all this IMR, under 5 and neonatal, most common is prematurity. So do remember this difference and this definition being already asked in INICET exam. Chalo, next question is HIV sentinel surveillance, which has been asked in last INICET also. What is the purpose of doing it? So if you want to know that in Bihar HIV is decreasing or increasing, what you will do is you will test 250 high risk group people, 250 bridge population, and 400 ANC mother. And in these 900 people, if in 2024 prevalence of HIV came 0.25, and in 2025 prevalence of HIV suppose came 0.2, it means HIV is decreasing in Bihar. So we are getting this prevalence of HIV decreasing with the help of HIV sentinel surveillance. So what does HIV sentinel surveillance tell us? It tells trend of disease. That disease is HIV is increasing in Bihar or decreasing in Bihar. Trend of disease is told by sentinel surveillance. And in the sentinel surveillance, when we go to high risk group and bridge population, we go and do the surveillance. So this is active surveillance. And we all know ANC mother, they come to hospital by themselves. So this is passive surveillance. And this was one of the question I'm forgetting in NEET or INICET, that if patient is having cancer and this cancer patient is reported to hospital, so which type of surveillance is it? So because here the patient is coming to hospital by themselves, they are reporting themselves, so they are passive. And passive is known as notified because of it, because these cases of cancer will be written in the register, so they are notified. So do remember, active is for hidden case, passive is for cases which are notified, registered. And if you mix active and passive, then it becomes sentinel surveillance. So sentinel surveillance is for all cases. Okay, and the purpose of doing sentinel is to know the trend of HIV. And also remember about active and passive. They ask a similar question on this, that in the Mahakumbh in Allahabad, there was a team of doctors who was roaming around the tent and they were trying to find which thing. So they are trying to do the surveillance for an outbreak, that if outbreak of any disease occur, that they should know it early. So what was the part of that doctor team in Kumbh? The part of that Kumbh thing visit was surveillance for outbreak. And if suppose you are the one person who is in the team who is looking for surveillance of outbreak in Allahabad Mahakumbh, and you found that some people are having loose motion in one tent, some Babajis are having loose motions. So what is the first thing which you will do for outbreak investigation? First step of outbreak investigation is you will take the sample to some lab for confirmation of diagnosis. This is the first step, confirmation of diagnosis. Of course, you will not take it in your hand, it will leak out. You will take it in some dish or something. So do remember, outbreak, first step is confirmation of diagnosis. And within how many time we should report outbreak? In 24 hours, you should report it under IDSP program, Integrated Disease Surveillance Program. You should report it within 24 hours. So do remember that sentinel surveillance is for monitoring disease trend, and first step of outbreak confirmation, outbreak surveillance is confirmation of diagnosis, because based on diagnosis we start treatment. So first you should diagnose what is the disease. Second thing which they ask again and again in HIV sentinel is which group is not included in sentinel. So we have to know what are the 7 people or group who are included here. Group is 3, but 7 people we do sentinel surveillance. Who belong to high risk group? Does doctor belong to high risk group for HIV? No, don't give yourself so much of importance. You have not performed that well. Sex worker come in this group. You need to improve your performance to come here. Then other than sex worker, there is transgender who come under it. Then there is MSM, male having sex with male. They come under it. And intravenous drug user, they come under it. So these 4 are high risk group. In the bridge population, there is truck driver and single migratory worker. Because why they are bridge? Because they go to sex worker, some of them, and sex worker are mostly living away from society. So they go there, take their HIV and bring it to their innocent wife back at home, to ANC mother in general population. So they are taking the HIV from separate part of society to general population. That's why they are known as bridge population. And what are the 7 people? Let's revise it. High risk have sex worker, transgender, MSM, IDU. Bridge population is truck driver and migrant worker. And last is ANC mother. So total 7 people are here who are part of HIV sentinel surveillance. Okay. Chalo. Now, next question. In a population of 200 people with normal distribution, how many people would be included in one standard deviation? So this is a trick question they are asking. I hope you know, within -1 and +1 standard deviation, there are 68% people. And 68% of 200 you have to do. So 68% of 200 is 136. So 136 people will be inside it. But sometimes they trick you in another way. They ask this question with a twisted way, that how many people are between mean +1 standard deviation? Will it be 0.68? Will it be 0.47? Will it be 0.34? Or will it be 0.95? So remember, if they ask mean +1 standard deviation, then they are not asking the whole 68%. They are only asking this white area, half of 68. And half of 68 is 34%. So mean +1 is 0.34. Plus -1 is 68. Okay. And how many people are outside mean +1 -1? Inside is 68. So outside is 32. Outside mean +-1 standard deviation is 32%. Because inside is 68. So remaining is outside. Next question is, if you found highest mean, which type of a skewed curve is it? So do remember this one point, that whenever we draw a skewed curve, this topmost point is always mode. Because this is the most commonly repeated number. So mode is always on top. Just like model want to be on top, that's why mode is on top. Like model want to have top of curve. So I suppose, you can see I am also a model and this is my top curve. So just like model want to have top curve, mode is also on top of curve. Just like model keep repeating itself, similarly mode keep repeating itself again and again. So mode is very much like model. And remember, median बीच का है. median is always between mean and mode. So median is always in center and mean is towards the skewed end. So in a positive skewed curve, only remember one line, that positive skewed curve, because mean will be around 80 here, median will be around 60 here, mode will be around 30 here. So you can see between 30 to 100, you have the skewed part, stretch part. Stretch part is going towards bigger number, 30 to 100. And in life, if you are going towards bigger number, it means you are also positively skewed. So if the skewed part is towards bigger number or right hand side, we call it positive skewed. And in positive skewed, do remember, positive skewed, mean is greatest. You just have to remember this line, mean is greatest in positive skewed curve. If you remember this line, you can always remember that whenever there is positive skewing, the sequence will be mean, then median, then mode. Why? Because you just remember mean is greatest, median beech ka hai, so median will be in the center and then there will be mode. So that's why positive, mean, median, mode will be there. And now because you know mean is greatest in positive skewed curve, so which will be greatest in negative skewed? Very good. Median can never be the greatest. So in negative skewed, mode is greatest and sequence will become mode, median, mean, because median beech ka hai. So if mode will be the greatest, sequence will become mode, median, mean. So you need not to mug up the sequence. Just remember two lines. First line, mean is greatest in positive skewed curve. Second line, median beech ka hai. So then in the positive skewed, the sequence will be mean, median, mode. And in the negative skewed, the sequence will be mode, median, mean. Okay. Now there is a very interesting question, second part of question which they ask from here. Let me get the blank page to tell that. The question they ask from here is, they give you a box and whisker plot. I just told you it is used to identify outlier. And sometimes they put the bar below, sometimes they put the bar above. And then they ask, this plot A, is it positive skewed curve or is it negative skewed curve? So can you answer this? Try to answer it. Dekhna. Any question, anything in the group chat? Which type of curve it is? Is it positive or negative skewed curve? Huh? Very good. You were able to answer stratified and you are answering most of the question. Very good. Dr. Shivam Sarma, Sushmita, Javed, Singapura Karthik, you, Nico, all of you, Hikko, Nico and Humanoid AI. You all are answering actively in the group. Thank you so much for being here. Do tell me, is it this plot A, is it positive or negative skewed curve? How to answer such question? You know, what is your answer? Nico is saying A, positive skewed curve. Okay. So remember, always 25% is below, 75% is above. And if you draw a curve, imaginary curve here, this will be the skewed part between, let's say, 40 to 75. Skewed means khicha hua hissa, tedha hissa. So you can see the skewed stretch or not straight part, skewed part is between 40 to 75, which are bigger number. So you can see here skewed part towards bigger number. And if you are towards bigger number, you are positively or negatively skewed? Positively skewed. So because the skewed part towards bigger number, this will be an example of positive skewed curve. Very good. Now this will be an example of negative skewed curve. So it's simple to understand with logic, but under exam pressure, you can get confused. So there was a student in Rajasthan who came to me in the interval gap and he said, sir, I will tell you a secret method to remember it, but don't tell other people about my name. I said, okay, tell me what is the method. He said, sir, imagine this bar as penis or thought of sex. And when the penis or thought of sex is below the belt, under our control, then our mind can focus in study, our marks will increase, and we are positively skewed. But whenever this penis or bar or thought of sex is in our mind all the time, this is the time when we don't focus on study and our marks go down. So when the bar is above, negative skewed curve. When the bar is below, positive skewed curve. Danda niche, positive. Danda dimag mein, negative. Okay. So do remember, bar below positive, bar above negative. Now I applied the same concept in learning one of the most toughest formula for me. That was the formula of positive and negative likelihood ratio. Because this formula rarely asked, but sometimes they can give direct numerical on it. And in both the formula of positive and negative likelihood ratio, we always write sensitivity by specificity. Always sensitivity is above, specificity is below. सेंसिटिविटी इज अबव, स्पेसिफिसिटी इज बिलो। द डिफरेंस किसका है? केवल डंडे का। अब देखो कितना आसान है। पॉजिटिव में डंडा कहां था? डंडा और पेनिस बेल्ट के अंडर था, कंट्रोल में था। इन पॉजिटिव skewed curve the bar was below the belt, under our control. So similarly, if you put one bar, one minus sign below, it become positive likelihood ratio. But in negative skewed curve, where was the bar? Above. So similarly, if you put one bar above, this become negative likelihood ratio. So with the same concept, you can remember box and whisker plot positive negative skewed and positive and negative likelihood ratio also. Remember bar below positive, bar in the head negative. Okay, same concept. Chalo. Now let's move ahead. The next question was this. Yes, this is a strange question. That disability certificate for poor vision 4/60 is how much of impairment percentage? So remember 100% when we give when there is no perception of light, then we give 100% blindness. We give 75% certificate if it is between 3/60 to 6/60. Then we give 75% percentage. Okay, and we give 40% if it is till 6/18. If someone is 6/18, then there is no disability, nothing. And if someone is between, let's say, 6/24 to 6/60, then we give this 40. 40 is to for that. But mainly they ask 75 and 100%. Remember 100% no perception, 75% if it is 3/60 or 6/60. Okay, in between that range 75%. Chalo. Next question is this prevalence of disease is given. It is 50%. And investigator is interested in the range of 45 to 55% with 95% confidence interval. Find minimum sample size required. So they are asking the sample size. And for calculation of sample size, there is a formula 4PQ by E square. This formula we rarely use, but this question has already came in AIMS exam. So if it came again, how will you solve such question? What is P here? P is the prevalence. How many people are suffering from disease? That is P. And in this question, they have written the prevalence of disease is 50%. So prevalence is 50%. Okay. Then what is Q? Q is 100 minus prevalence. So because prevalence is 50, what will be the Q? 100 minus 50, 50%. Now, what is E? E is effect size. We call it precision. Effect size or precision. And usually they give the precision in the exam. But if they have not given, you will take precision as 5%. But here they have given the precision. They said investigator is interested in the range of 45 to 55%. So 45 to 55 and prevalence was 50. अब देखो 45 to 55 means 50 plus minus 5%. If you do plus 5, it becomes 55, minus 5, it becomes 45. So that means what is the fluctuation? What is the precision? Precision means how much is the fluctuation there? Fluctuation is 5%. So E is 5 and we will do 5 into 5 for 5%. 4 is 4. What is the prevalence in this story? 50%. What is the Q? 50. So all the 5 will cancel out. 0 will remain 4 0. It's 400. So what is the sample size which we got? 400. Do remember this point. If they have not given any data and they just ask you sample size for a new study. If you want to do a new study, what will be the sample size? Answer will be still 400. Because for a new study, prevalence is taken as 50% like this question and effect size or precision is taken as 5%. So for a new study also, answer will be same 400. And I do remember sometime they can give this calculation also. Next question is, they are asking you by giving the prevalence of Candida glabrata infection to be 80%. So prevalence is 80%. Now, what else? Population they have given 100. That means sample size they have given 100. If the test is repeated with for 95% confidence level, what will be the range of prevalence for Candida glabrata? This is not, they are not asking confidence interval, they are asking confidence level. And they have given the population word. So do remember, in the question, if they use population, then for 95% confidence interval, we use the formula mean plus minus 2 standard error. If population is given, we use standard error. But if population is not given, then the formula become that, I hope you know, then the formula become 95% confidence interval is mean plus minus 2 standard deviation. So standard deviation we will use when the population word not given. Population not given. If they have given the word population in the question, then you will use standard error. And for standard error, there are two formula. First formula for standard error is standard deviation by under root of sample size. Second formula is standard error is under root PQ by N. So because there is two different formula, why there is two different formula? Because there are two type of data. One data is which we can measure, quantitative data, which is also known as continuous data. Like you can measure my weight, you can measure my height, BP, BMI, all the thing we can measure is quantitative. But the thing which we cannot measure is qualitative or categorical. An example of categorical data is all disease come under categorical. Like, can you measure my obesity? No, you cannot measure it and say, sir, you are 2.8 obese. You can only say, sir, you are mild, moderate, or severe obese. So disease is categorical. Disease is qualitative. Do remember, all the things which come in percentage, proportion, median, mode, they are qualitative or categorical, and all disease are qualitative, categorical. Why this information is so important? Because they will ask, where do you apply chi-square test? So if there is two or more group where we are talking about disease, percentage, proportion, qualitative data, then we will apply chi-square test there. So here, the data is in percentage, and I just right now say that if the data is in percentage, it is qualitative data. So here the formula which we have to apply is that 95% confidence level is equal to prevalence plus minus 2 under root PQ by N. We will apply the lower formula because the data is in percentage prevalence. Now if you try to solve it, the answer will come 80% is the prevalence plus minus 2 into under root PQ. What is P? Prevalence. Prevalence is 80. What is Q? 100 minus P. So if you do 100 minus 80, it becomes 20. Divided by sample size, how many is the people? 100 people, so 100 below. So if you put 100 below, this 20 will cancel this 20 and it will come under root 16. So it will be 80 plus minus 2 into under root 16. Under root 16 is 4. So it's 80 plus minus 2 into 4. 2 into 4 is 8. So 80 plus minus 8. 80 plus minus 8 means 72 to 88%. So answer is 72 to 88%. Now I know what you will say, sir, will they give such big numerical in the exam? Answer is, chance is rare, but they are giving calculator. And many a time they repeat the same data. So I gave this question here so that if they repeat the same data, answer you can mark directly 72 to 88. Okay. So this was a question based on this bigger formula calculation. Very rarely they ask question on bigger formula. Mostly they ask is on this only, that 95 is mean plus minus 2 standard deviation, because mostly they don't give the population word. Okay. So next question is, ki human poverty index include all of the following except. Remember, human poverty index is complementary to HDI. Complementary to human developmental index, HDI. And this is a very common question, which thing are in PQLI, which thing in HDI. And it's not at all confusing. If you just focus for 2 minutes, you will remember it. When we write PQLI, can I write it as L1? So in PQLI, first thing is life expectancy at 1 year, because it is L1, so 1 year. Second thing, if you write PQLI, I is also for infant mortality rate, which is the best indicator of accessibility and affordability of health system. Because if health system is nearby, accessible and free, affordable, then home delivery will be less, and infant death will be less. So who is the best indicator of accessibility, affordability of country's health system? That is IMR. This question came in NEET already, do remember. And IMR also tell best about the impact of ASA work, because if ASA is working well, IMR will be less. So PQLI tell about IMR. And then L, what is L? L means literacy rate. So what are the three things in PQLI? Life expectancy at birth, I for MIR, L for literacy rate. You can remember it. One more thing is PQLI are 4-letter big. So the range is big, 0 to 100, because it is big. Now let's focus on HDI. HDI is small, so the range is small, 0 to 1. And HDI is good for highly developed country. So in highly developed country, first thing is life expectancy at birth we measure. Second thing, in highly developed, we don't measure literacy rate, we measure mean year of schooling. Because in highly developed country like US, UK, बच्चा English बोल रहा है ना, even the child is speaking English. So we don't measure literacy rate, we measure mean year of schooling. One more thing is, where do per capita income matter? For highly developed country or for poor country like India? Per capita income do not matter for India, because in India, only 2% population have 90% of country income. So if you include that 2% population who have 90% of India wealth, then our GDP will look okay. But if you remove that 2% population, our GDP will go doom below the ground. So when BJP government is saying that Gujarat per capita income is increasing, actually they are trying to say Adani per capita income is increasing. It's depend on that 2% population who have 90% of country wealth. So per capita income do not matter for India, because it depends on that 2%. So remember, per capita is for highly developed. For India, we have IMR. That's why if they ask which is the better indicator is PQLI, because it includes IMR. So PQLI is better indicator. Now, what is human poverty index? Complementary to HDI means it will have the just opposite thing which are there in HDI. Like HDI have per capita income. So human poverty index will have people who are below poverty line. So first thing in human poverty index, HPI, what are the things in HPI? First thing is, in HPI we measured population BPL, below poverty line, first thing. Second thing, in HDI we are measuring mean year of schooling. So in human poverty index we will measure illiteracy rate, that how many are illiterate, how many are not able to go to school. Second thing. Third thing, in HDI we are measuring life expectancy at birth. So in human poverty index, the third thing we will measure it, population who died before 40 years. Not life expectancy but death, not income but BPL, not mean year of schooling as HDI but illiteracy rate. So it is just complementary. So what are the things which we are measuring? We are measuring probability at birth not surviving till 60 years. Yes. We are measuring percentage of population not using improvised water source. Yes. This represents BPL. And we are measuring illiteracy rate. But we are not measuring child literacy rate. We are measuring illiteracy rate. So this is one thing which is not measured there. And when we say percentage of children underweight for age, this is again something which is telling that due to hunger, poverty, the malnutrition is there. So we do not measure literacy, we measure illiteracy rate. Underweight for age also is something which tell about BPL category and poverty, so we measure it. Similarly, they ask this question on one more thing you should know, global hunger index. The question is, which of the following is not a criteria of global hunger index? Not a criteria. Okay, so not a criteria is IMR. And what are the criteria in global hunger index? To remember it, you can use the mnemonic FUCK-US. FUCK means under 5 mortality rate, U means underweight, and S means stunting. And if you look at Poshan Abhiyan, this Poshan Abhiyan has 5 programs under it: Anemia Mukt Bharat, Adolescent Health Program, Anganwadi Program, Nikshay Poshan, PM Poshan. 5 things are under it. And if you look at the target of Poshan, They are saying that the target of portion is 2% reduction in underweight, stunting, and low birth weight. So a student in Mumbai, he gave me the mnemonic lusty, lust 2%. L is low birth weight. U and S are same. U for underweight, S for stunting. So global hunger index and portion, they both have underweight stunting. In global hunger index, it is under 5 mortality, so 5 F fuck US, hai na? And in portion, it is L for low birth weight, and it is 2% each year. So the target is for 3 years. In 3 years, how much you have to go? 6%. Similarly, in portion, there is also anemia mukt Bharat, and in anemia mukt Bharat, the target is 3% reduction in anemia. So anemia 3% reduction, but lusty 2%, hai na? Low birth weight, underweight, stunting 2%. Okay, and remember, in both portion and global hunger, IMR is not the criteria. Sure. Now, next question is, ki growth monitoring in Anganwadi worker, which growth chart we use? We use weight for age. Up to which age? 6 years. So in growth monitoring, which standard we are using? We already discussed it. We are using multi-centric growth research study, which was done on children from 6 countries, including India. That is MGRS study. Next question. If you want to know the estimation of prevalence of blindness by blind school survey, in blind school, blindness will be high. So you might think that the whole people are having more blindness. Now, you're not understanding it. Let me explain it properly. This is known as Bergsonian bias. What is Bergsonian bias means? It's a type of selection bias. And this Bergsonian bias simply means कि if suppose you are a psychiatrist, within 2-3 years of being psychiatrist, you and your whole hospital people will start thinking that in our area, depression is very common. Prevalence of depression is in 80% people. Why we think so? Because patient coming to hospital, they are having depression, and we start thinking that this is the actual burden of disease, but this is not the actual burden. So what is Bergsonian bias? This is also known as hospital rate admission bias. It simply means that the people who are coming to be admitted in a hospital, they are not representing actual burden of disease. Like for example, if I ask, usually in class I ask that how many of you think people in the world are full with depression, problem and all? Do you think 80% people have depression and problem? Usually 90% students raise their hand that yes, people are depressed and problem. I said you think so because this is your Bergsonian bias. You are a doctor and you are dealing day in, day out with disease and problem. So you think this is common thing. But imagine if you are a DJ in some club in 𝐒𝐻𝐿𝐿 or somewhere. Every night you are just dancing and singing. Do you still think that the world is full of problem? No. Then you will think that world is full of happy people. So the people who are coming to hospital, they don't represent the actual burden. They represent a very high burden. Similarly here, if you do a survey of blindness in blind school, you think that prevalence of blindness is very high, but it's not actually very high. So you will do overestimation. Let me give you a simple example. For 3 months, while doing my MD in PSM from AIIMS New Delhi, they posted us at sex and marriage counseling OPD. And when I was working there as a sexologist, in 3 months, I started feeling that problem of sex problem is very common. People are not doing sex anymore these days. Why I started feeling it? Because whoever used to come and I used to ask how many times you do sex in a week or in a month, they used to say once in a week. I said once in a week, are you doing fasting or sex? But they are, because they are the patients who are coming with sex problem. It's not the actual burden of disease. So this is Bergsonian bias, that patient who come to hospital, they do not represent the actual burden. They are usually giving us an overestimation of disease. Like here, you go to blind eye, you think blindness is common, but it's your overestimation. Okay. So now, and do remember, Bergsonian bias and volunteer bias, both this bias, they both are example of selection bias. Whenever you do any survey or any study on volunteer are very healthy or very sick. They are different from general population. So you will have wrong selection of people if you do study on volunteer. है So volunteer bias works on, they both are selection bias, and works on in hospital rate admission bias. If anything is not clear, you can ask me again in the chat group also. I will be more than happy to answer your doubt. Chalo. Now, next question is, the recommended daily intake of iodine in pregnancy is, this is where there is a bit of controversy, but they say iodine in pregnancy is 250, which is here, and iodine in lactation period, iodine is 280 microgram, okay, per day. So pregnancy 250, lactation 280. But if they ask about calcium, calcium in lactation is 1200 milligram. So is old age also, they need the same amount, 1200 milligram of calcium. But if they ask in pregnancy calcium, then it is just 1000 milligram, not 1200. In adult male and female also, it is just 1000 milligram. So calcium is 1000, 1200. Iodine is 250, 280. One more thing they can ask is the extra calorie. The extra calorie which we need in pregnancy is 350 kilocalorie per day. And the extra in lactation is 600 kilocalorie per day. Okay. Do remember these important things. All of the following are common diseases of epidemic after disaster. Most common is, remember, most common disease during flood or disaster is gastroenteritis. Gastroenteritis. And remember, I discussed it there, that most common is gastroenteritis. Second number is leptospirosis. Then there is cholera. Then there is rickettsial disease. And then there can be some, this thing, mosquito transmitted disease. So leishmaniasis is transmitted by sand fly, and it's not so common. Leishmaniasis grow, it's a something which grow in the cracks of the wall and all, and it, sand fly do not fly, it only jump up to 2 meters. So sand fly leishmaniasis, kala azar is more common in of course in the 4 states are endemic: Bihar, UP, then brother of Bihar, Jharkhand, and West Bengal. These 4 states are endemic. Remember, Assam is not endemic for kala azar. So leishmaniasis or sandfly disease can also be there, and acute respiratory infection can also be there. They both can also be there. But which are common causes of epidemic after disaster? So this sandfly leishmaniasis can call epidemic, rickettsia leptospirosis can call epidemic, but acute respiratory infection epidemic do not occur due to natural disaster. This ARI or flu epidemics occur due to frame shift mutation in type A influenza virus, which occur after 10 to 11 year of period. So it is an example of cyclic trend. Or do remember which influenza virus is most common, A, B, or C? A is most common because type A is causing pandemic. So all pandemic or shift occur in type A, and that occur due to mutation and all, not due to the flood. Okay, chalo. Now, highly toxic insecticide according to WHO are classified in not in red but in yellow. This is a controversial area. If they ask extremely toxic, then answer is red. Red is extremely toxic. An example of red is zinc phosphide. Zinc phosphide is same thing, which is a rat killer, which was distributed in some Panthathemia district of Kerala after leptospirosis outbreak was there during flood. And this is the symbol which you can see on some insecticide. Or if you turn your vaporizer, mosquito vaporizer, on the back side, you will see a green color logo like this. So green means safe for human use. And if it is red, it is extremely toxic red. Example, zinc phosphide. If it is yellow, yellow is highly toxic. Example is indosulfan. And then if it is blue, blue is moderately toxic. So remember, highly toxic is not red, it is yellow. And blue is moderately toxic. Example of blue is malathion. Do remember, this question has also come, that malathion is something which is least toxic organochloride. And after how many times you will respray malathion? After 3 months, we respray malathion. 6 months is the respray time of DDT. The next question was that which of the following is not true about screw feed technology? In screw feed, what we do, this is a big machine where we put the plastic waste, mostly the RL and NS bottle, which occupy the maximum space. And then what are these? These are not flour, these are blades which are cutting those plastic waste, and finally it will come out as a pulp of plastic. So screw feed technology, will you cut my leg or placenta in through screw feed? No, because it will only spread the blood all around. So screw feed technology is not for pathological waste. Screw feed technology is not with HIT. It is just cutting them into fine pieces. So there is nothing with HIT. Screw feed can never reduce the weight. Weight will be same, but it will turn the RL and NS bottle plastic into pulp of plastic. So it will reduce volume by 80%. This is the role of screw feed technology, and it is used for red category, for plastic and rubber. Mostly the plastic thing we are using screw feed. Second thing which they ask from here, similar question, is about inertization. Suppose you are in a small peripheral hospital and there is a mercury thermometer or BP machine which break down. So the ideal way of disposal of mercury is collect and recycle, or send it back to manufacturer is the best way. First way is collect and send it back to manufacturer under yellow wooden box for cytotoxic drug. But if you cannot send it back to manufacturer, you can recycle it. But if you cannot do both, then you will mix it with 15% cement plus 15% lime. If you will mix it with cement and lime, it will not pollute the surrounding water or underground water and other thing. So it will become inert, susupt avastha mein chala jayega. It will become inert, do not contaminate surrounding, and then we can dispose it easily. So inertization is for pathological, cytotoxic, radiological waste, and it is 15% cement, 15% lime. Second method in screw weight. So ITP, immunothrombocytic purpura, is something which occur with MMR vaccine side effect. Okay, the very common side effect. Second problem with MMR is it can cause anaphylactic shock. So we never use MMR vaccine after 4 hours of opening the vial, because MMR vaccine has neomycin and gelatin. So if anyone is allergic to any one of them, patient can die. And in MMR, the vaccine, anaphylactic shock can occur, but least common is SSPE, subacute sclerosing panencephalitis. This can occur with MMR vaccine also. This can also occur with MMR infection. And because it occur after 10 to 20 years of vaccine or infection, so no one know it is least common side effect of vaccine or infection. It's an interesting thing. It is actually least common side effect of both vaccine and infection. Okay. So this is for MMR. And do remember that sometime they ask it about rotavirus. Very commonly rotavirus, I hope you all know. The least commonest side effect which they ask is of rotavirus, intussusception, telescoping of intestine. One part goes under another. And remember, rotavirus is something which is not given after 6 months. So if a child came after 6 months, we don't give rotavirus. Do remember. Chalo. Next question is, positive predictive value is a function of sensitivity, specificity, and prevalence. We already discussed this question with the example of sex worker have more cervical cancer. So in sex worker, if you do any test of pap smear, the PPV of pap smear will be less, because PPV, positive predictive value, is directly proportional to prevalence. So if any disease is rare, PPV will be less. And PPV depend on 3 things. Which 3 things? Sensitivity, specificity, and prevalence. 3 things decide PPV. And this is Bayes' theorem, which we discussed while doing the second or third question of the today's session. You can go back and check that also. Now, a boy complained of unprovoked bite by a local dog. Unprovoked bite is like, it's high chance of rabies. The dog was later caught by a local animal authority and appeared to be healthy. Appeared to be healthy. We don't know whether it is actually healthy or not. The most appropriate course of action would be give post-exposure prophylaxis to the bitten person with cell culture derived vaccine. So of course we have to give the vaccination. Withhold vaccination can never be the correct, because it was an unprovoked bite. Even if it is an provoked bite, we don't delay the vaccination. We never withhold vaccination. So B can never be correct in any case scenario. Now sometimes they trick you and they ask, the dog is fully vaccinated, then will you consider the vaccination? Answer is no, because we don't know what is the vaccination schedule of dog, and every owner of dog say my dog is fully vaccinated, then get your bum bitten by it one time. So never withhold vaccination. And if any dog owner or anyone is saying dog is vaccinated, do not give importance to it. Whether the dog is vaccinated or not, management will remain the same. Now look at the third option, test the dog for rabies. Why are we testing dog? We just have to give the vaccine to the child first. Immediately carry out euthanasia of the dog. Why all this focus on dog? And I only give post-exposure prophylaxis. And do remember when very tricky question they ask, that you might have watched some Instagram reel and all, when some girl or boy, they lapalap, they do a smooch with dog. If the smooch is there, is it category 1, 2, 3? Will you give immunoglobulin or not? Answer is yes, it is category 3. If there is licking on mucosa, so you can smooch any dog type of boy, but don't smooch a dog. Okay. Second thing, if neighbor dog came and scratched my bum with just one drop falling, will you give immunoglobulin? Answer is yes. So if there is minor bleeding or one drop also, it is category 3. Second question, third point, if they gave this point that suppose the dog came and scratch not my bum but my face, and there was no bleeding, now will you give me immunoglobulin? Answer is again yes. So if there is minor bleeding, lick on mucosa or a scratch on face without bleeding also, then also we will give immunoglobulin. And the fourth case where we give immunoglobulin is bat bite. So in these 4 cases, we give rabies vaccine plus human immunoglobulin. These are category 3, do remember. And the dose of human immunoglobulin they ask, it is 20 international unit per kg. Half dose we give around wound and half dose IM. But if there is nothing around wound, let's say he was about to bite my bum, but I put my hand there, you cannot give half dose around my hand. So then you will give full dose IM. So remember, 20 international unit for human, and these 4 are category 3. And here answer will be A. Now let's come to next question. In a school vision, who does the screening? So the screening is not by doctor, this is by teacher. Do remember, this school health program, they ask this question again and again. It comes under which thing? So a school health program come under vision center. And what is vision center? PHC. Under Vision 2020, Government of India thought we will make 20,000 PHC as vision center. So they made PHC as vision center, where we are doing screening for refractive error, and teacher is also screening. So both are screening. That's why school health program come under vision center, which is at PHC. PHC vision center look over school health program, and teacher get 1 day training at the school, then come and screen 150 children or 4 to 8 class. They ask all the children to stand in queue, then on a pillar they put Snell chant and then read from another eye, go like that. So remember in this thing that school health program previously was only under PHC, but now it is also under Ayushman Bharat. Why they have included in Ayushman Bharat? Because government is planning that on Tuesday, especially on Tuesday, Hanuman Jayanti, linking yoga with Hindu religion. That's why they on Tuesday are celebrating Health and Wellness Day. So this Health and Wellness Day, they can ask on which day? Tuesday, because of Hanuman Jayanti, you can remember. What they will do is they will choose one boy and one girl. For what? For couple dance? No. They will be chosen as Health and Wellness Messenger. And then they will have one male teacher and one female teacher. For what? Couple yoga? No. They will be chosen as Health and Wellness Ambassador. And they will teach student yoga and meditation on Tuesday, क्योंकि yoga से सब होगा. Everything will happen with yoga. So they are focusing on yoga, and it's a good thing. We should be supporter of that yoga thing, but it's not related to any religion or any political party for sure. And it's something which is free. So no one can give it to you. And it's something which you already have it. I cannot give you exercise. And you already, if you do, you have it. So do remember, school health program come under Ayushman Bharat, PHC Vision Center, and this Health and Wellness Day is on Tuesday. one more very important thing in school health program is how much area is per student. So per student is 10 square feet per student. Similarly, they can ask the area in occupational health. Then in occupational health or factory at how much area? So area they give was 500 cubic feet. But then all the factory owner, they started making rooftop very higher, saying that see 500 cubic feet. And therefore the government put this line and that only 14 feet above head counted. We count only 14 feet above head. Otherwise, the factory owner will count the space and they will say we have given the 500 cubic feet. So remember the space is 10 and 500 in occupational health, but only 14 feet above head. Chalo, next, I should have written that part here, but anyway. Next question is that under Janani Shishu Suraksha Karyakram JSSK, this logo came in NEET exam and the logo has a yellow color mother, yellow color child. How will you remember? Remember there is Sishu who keep on doing susu. Sisu means infant, keep on doing urination. So the logo is yellow mother, yellow child. And in JSSK we give free food, free transport, free treatment, but we don't give any cash to the mother. Cash for institutional delivery is under JSY, not under JSSK. It is under JSY. Next question is ki, okay, if there is the space, let's discuss it. How much cash is given to which category? This question has came one time that urban MP mother delivered. How much money is to Usha and how much money is to mother? Can you answer it? So first thing, do remember that in urban area, always Usha or Asa, they can call Asa as urban, Asa as Usha. Na? So Usha can be called as urban Asa. Always get 400 rupees. So Usha urban area, as soon as I say, they answer 400. That is point is done. And if they say Asa, Asa gets 600. So Asa Usha money is fixed, 400, 600. Now only you have to focus on mother. And if mother are from rural area, of course they should get more money. Urban area should get less money. Okay. Now, if the mother belong to low performing states, what are the low performing states? Very simple to remember. First is United States of Bihar again, then the two neighbor UPMP and their forgotten brother Jharkhand, Uttarakhand. We have a UK also in India, and Chhattisgarh, my favorite state. So 6 is done, and then the 4 are Roja Jane Man, hai na? Rajasthan, Odisha, J&K, Assam. So total 10 states are low performing states. In rural area we give 1400. In high performing states rural area we give half of that, 700. In urban area, low performing area, we give 1000, and half of that we give is 600. So half of that is 500, but we never gave mother less than Asa, so we give 600. So we are talking about mother here. Mother 1400, 700, 1600. Asa always gets 600, USA always get 400. So if the mother is in urban MP belong to which state? Low performing. Urban area, mother how much get? 1000. So answer is 400 and 1000. Like that you can answer the money part in JSY. Next question is, you calculate neonatal mortality rate for a population according to the data of 2012. Number of neonatal death is 450. Number of stillbirth is 212. Total number of live birth is 12,450. So this is a tough calculation which came very old, which came in 2014 in INICET. So let's try to do it. Neonatal mortality is something we know, death in first 28 day. Number of neonatal death they have given 450. So numerator will be 450. Multiplication is always 1000. We divide it by live birth. So live birth simply means total number of live birth is given 12,450. So we can directly write is 12,450. This time we need not to subtract 212. If they have written total birth, so total live birth, if you have to find, then this is total birth minus stillbirth. When they give total birth, then we subtract stillbirth. Here they have directly given total live birth. So they have given the total live birth is 1200, 450. So this 1200, 450 is already given as total live birth. We need not to do any subtraction here as such. And anyway, the stillbirth is only 212. But I think there is some error in the question itself. Let's solve it, then the answer will come correct. If it is 450 by 12,450 and then 1000, then let's do it assuming 12,000. The calculation will be easy. 450 by 12 will be the answer, because this 30 will cancel this 30 if it is 1200. If so, 450 by 12 will have 46 by 3 time, so it will be 2.9 or something, and then 0. So 29 or 30 will come here. 29 or 30 will be the answer here if you see 450 by 12. So if you find answer around it like 36, that will be the answer. So why I choose this question? Because calculation is sometimes very tough. Like it's very tough to calculate 450 by 12, 450 in 2000. So in these cases, you can do a rough approx calculation. Consider it not as 12,450, as 12,000. Remove the 3030. If you remove it, answer will be 450 by 12. And we all know 12 into 3 time is 46. No, 12 into 2, 3, 4 time is 46. Oh, sorry. I did a wrong calculation here. 12 into 4 time is 48. So it will be, I did the calculation correct. It will be around 36 which will come out. 3 time if you will cut, it will be 36, and then 9 is left. So 3 and then 900 is around 30, around 36 will come. Not directly, but around that will be the answer. If you want to go exact, you can go exact and calculate this data. It will come around 36. So in such question, you can do approx calculation, and that can also give you the correct answer if you don't want to do the exact calculation. So now, infant mortality rate include all of the following, except we discussed. Infant mortality rate do not include stillbirth and do not completely include perinatal death. It include part of perinatal death, but not completely. Okay. Then a girl is having white hair. 40% of her classmates are also suffering from the same problem. None of the other people from the same village have white hair. Only the children have it. Her brother, who is staying with an aunt in the neighboring village, is also normal and does not have white hair. So because brother have no problem, it cannot be genetic. And they're asking which can be the reason. So here, girl is having white hair and 40% of her classmates are having white hair. None of the other people from the same village have white hair. So if it is an environmental problem, in the village also there will be other people who will have it, because they are living in the same environment. So it's not an environmental problem also, because they have given none of the other people in the village have it. Then if it is nutritional, again nutritional problem will remain in all the group. It's some kind of infection which is there in the students, but student infection causing white hair is rare, but it can be some fungal infection or some other infection which can be there. Why it cannot be environmental? Because none of the other villager have it. Why it cannot be genetic? Because the boy do not have it, and therefore it most likely goes to infection. It's like ruling out, we can answer it. But there are two questions which they ask similar to those questions. One is this question they ask, in a village, people are eating rice and pulses mainly, and the village name they have also taken Chhattisgarh. It's not a village, it's a state, my favorite state actually. But they have written Chhattisgarh farmer are eating rice and pulses, and they have spasticity of lower leg. So if there is a spasticity of lower leg, what is the reason? And the student think it is vitamin B12 deficiency, because they are eating rice and pulses only, vegetarian diet, so vitamin B12, and they answer SACD, subacute combined degeneration. But no, this time the spasticity of lower leg is due to neurolethyrism, because they have mentioned this Chhattisgarh and rice and pulses. Pulses can also be khesari mixed with arhar, and a khesari is something which is mixed with arhar to lower the price of arhar. Arhar is a common pulse which we have in our diet and in summer also. So neuroletharism is the disease here. If they talk about spasticity and liver leg, sometimes they present neuroletharism as cross leg walking on toe. So if they say cross leg walking on toe, that is also neuroletharism. The poison is beta oxalyl aminoaniline and the drug of choice is vitamin C. But how do you remove BOA? To remove BOA, we can do parboiling. Put this khesari in lime water, chuna pani overnight, and it will remove the BOA. One more question they ask very frequently is from the poison sanguarine. So this sanguarine, if you see, start with S, and S is also for sleeping. Sang means together. So imagine if you are sleeping together with someone of your dream. First you will not sleep, but if you sleep, there will be dropsy. So in sanguarine, which disease occur? Epidemic dropsy, because sleeping will have dropping of eyelids, so dropsy. And second thing is, if they give sanguarine, they will talk about mustard oil contaminated with seeds of Argemone mexicana. And the symptom which they will give here is congestive heart failure and pitting edema. So you can see it here that this is also dropsy going inside. Now the recent very good question which came from here is the sanguarine poisons, S for sleeping, S for sanguarine dropsy, is detected by nitric acid test and paper chromatography test also. So which one is better? So better is paper chromatography test. Okay, I have confirmed it from Park. It's there, paper chromatography. Nitric acid is not better, it's second option. Okay. So sometimes they ask, if they ask the option, paper chromatography is better. Similarly, they ask this tricky question with this thing with kata thermometer also. That I hope you know, kata laga. Kata will always be thorn. Kata means thorn in English, and kata is always sharp and pointed. That's why if it is kata thermometer, it will be long and red color. If it is globe, it will be like this. So globe thermometer, I hope you all know, it measure radiation temperature by absorbing the radiation of the room. Globe thermometer will measure radiation temperature. But if it is kata thermometer, it can measure cooling power and air velocity. So if they ask which one it measure better, so better it measure is air velocity. And then second thing which it measure is cooling power. So it measure two things, but air velocity is something which measure better. So next question. Severe acute malnutrition in India is defined as, we already discussed, low weight for age cannot be used. Weight for age is for acute and chronic both. So low weight for age is not the answer. Severe wasting, yes. Presence of nutritional edema, yes, this is one criteria. And weight for height should be less than -3, yes, correct. By visible severe wasting or presence of nutritional edema. So this will be having both the criteria. So better answer will be D, because to define SAM, we need three things: weight for height less than -3, visible wasting or edema, and third is mid-arm circumference less than 11.5 centimeter. So this is red color. So if in any option they put all the three, that will be better than D. But there is no option with all the three things. So we will go with the better one here, which is D. Next question is the most sensitive indicator of environmental iodine deficiency. Environmental iodine deficiency occur in hilly area where iodine is less in the soil. So because of that, mother will have less iodine, and it is indicated by neonatal hypothyroidism. Hypothyroidism in children is best environmental iodine deficiency indicator. But if they ask best iodine deficiency indicator in population, so the best iodine deficiency indicator in population is urinary iodine excretion. And children are not having iodine in the urine, that will tell that in the population iodine is less. So remember, if they ask population best indicator or just they ask best indicator of iodine deficiency without environmental word, answer will become iodine excretion. But if they include the environmental word, answer will become neonatal hypothyroidism. Okay, so focus there. Plus at the factory level, it should be 30 ppm, and some part got evaporated. So when it come to house, it should be minimum 15 part per million. Okay. Chalo, next question is that this is a very tricky and very interesting question. They have given you the mean value of hemoglobin 10.6. They have given a standard deviation of 2. And they ask where is 5% of female will lie. What is the hemoglobin of 5% of female? So, first step of this all question is you have to find 95% confidence interval. And a lot of question come on 95% confidence interval. The formula is mean plus minus 2 standard deviation. So here standard deviation is 2. 2 into 2 is 4. And mean is 10.6. So 10.6 plus minus 4, if you do, it will be 6.6 to 14.6. Now, if you plot it in a graph, in this normal curve, suppose here you have minus 2 standard deviation at 6.6. And here you have plus 2 standard deviation at 14.6. And that's what it means, 6.6 to 14.6. So in between that, 95% population will lie. Now the question is, where is 5% population of the female lying? Where will you find 5% female? Will you find them at 6.6? Will you find them at somewhere around here like 6.3? Where will you find 5% female population? Okay. So we all know answer cannot be 6.6. Why? Because 95% are inside. So outside is only 2.5% population. Because inside is 95. So below 6.6, there is not 5%, only 2.5% population. Okay. And then if you go a bit inside, suppose you went till 7.3, then there is a chance that you can find 2.5% more. So how many will be below 7.3? 5%. Okay. So in all such question, what you have to do is first find lower standard deviation like 6.6. Then you will find the number which is above lower minus 2 standard deviation. Like above 6.6 is 7.3. So that will be the answer. Although in this question they wrongly put 6.68, it is actually the correct option was 6.38. So 6.3 will be somewhere here outside. And when below 6.6 is only 2.5, then below 6.3 is hardly 1% people. So answer can never be 6.3. Answer is just above minus 2 standard deviation, and here it is 7.3, which is better. Let me do this with one more thing. If they talk about screening of TB program, is best by sputum microscopy, because CBNAT is very costly. We do not use for screening. But let's come back to our question. Suppose they said for your class, in a class of 100 students, suppose they said mean weight of your student is 70 kg and standard deviation is 10. They ask 5% student का वजन कितना होगा? 5% student will weight below what kg? Below what kg 5% student will be there. So if they are asking 5% student, first step is the same. You will find 95% confidence interval. And for 95% confidence interval, the formula is simple. Mean plus minus 2 standard deviation. So in our example, what is the standard deviation here? Standard deviation is 10. What is the mean? Mean is 70. So 70 plus minus 2 into 10. How much will come out? 70 minus 20 is 50, plus 20 is 90. So 50 to 90 will have 95% student of your class. This is the class. 50 to 90 are here in between this 95% confidence interval. My question is, where will you find 5% student? Option R. Will you find them below 50, below 47, below 53? What is the answer? 50, 47, 53. Below which weight 5% people will be there. So one thing is clear कि 50 के नीचे केवल 2.5% है, तो 50 तो आंसर नहीं होगा क्योंकि 95 अंदर है तो 2.5 बाहर है, तो 50 आंसर नहीं हो सकता है। अब 50 के अगर हम बाहर गए 47, तो पहले ही 50 के नीचे 2.5 हैं, 47 के नीचे तो हार्डली 1% आदमी होंगे, 47 भी नहीं हो सकता है। तो सही आंसर क्या है? जो 50 के जस्ट ऊपर वाला है। जब जस्ट ऊपर 53 जाओगे तो चांस है कि 53 और 50 के बीच में एक्स्ट्रा 2.5% मिल जाए, और एक्स्ट्रा 2.5 मिल जाएंगे तो ये 2.5 और 2.5 जुड़ के 5 हो जाएंगे। तो what I was saying in Hindi was that because below 50 only 2.5% people are there. So below 47 there will be much lesser people. We cannot have to go below. But if you go just above 50, you may find 2.5% extra people between 50 to 53. And if you add that 2.5, total 5% people will be below 53. So answer will be 53. Do remember this thing. Where will you find 5%? 5% is just above -2 standard deviation. Just above -2, you will have 5%. Okay? Because only above -2, you can find the remaining 2.5% people. Chalo. Next question is, acha, one more thing is, if they ask screening, only screening, then answer is sputum microscopy. But if they ask screening for spread of TB, spread of TB infection, not TB disease, TB infection, then the answer will be tuberculin test or Montux test. Because infection is detected only by two tests, tuberculin or IgRA. And IgRA is very costly, so we can't do it in the screening part. So for infection, answer will become tuberculin. For case or disease, answer is Jaden smear sputum microscopy. And sometimes they ask in which investigation of TB we take whole blood sample of patient. Answer is IgRA. In IgRA, do remember, whole blood sample is taken. Whole blood sample taken in IgRA. No other test of TB take whole blood. And IgRA, tuberculin only tell infection. Jaden smear, fluorescent, CB-NAT and sputum culture, they tell the disease, the case. And what is the gold standard? Is it CB-NAT or is it culture in liquid medium? So remember, sputum culture in liquid medium, this is the gold standard. In liquid medium is gold standard, not CB-NAT. Why not CB-NAT? Because in CB-NAT, sometime over positive comes. You know, the Mycobacterium avium complex, some other brothers of Mycobacteria, they can also come positive. But if you are doing culture in liquid medium, you can see the colony characteristic and you will not overdiagnose like CB-NAT. So gold standard is culture in liquid medium, not CB-NAT. Although CB-NAT has an advantage that it can also detect rifampicin resistance while detecting TB bacilli, but still gold standard is culture in liquid medium. Next question is, which is true about ESI Act? Funeral benefit is 50,000. No. Funeral benefit is 15,000. Funeral benefit. Previously it was 10,000. Now the government gave 5,000 extra. And 10,000 for funeral, 5,000 for party. Sad party, but that's there. Then the state government give 1/8. Central government gives 7/8. This is totally correct. State gives 1/8. Central gives 7/8. This is totally correct thing. This is actually a correct statement. Person with daily wages of rupees 70 has to contribute 300. No. Person means employee, of course. Employee who was earning more than 15,000 per month, they give 0.75% of total expenditure. Because whenever you take insurance, you give some monthly premium. So employee gave 0.75% of monthly premium, and the employer, who is the manager, he should pay more. So employer pays 3.25% of total monthly premium. So if you mix employer and employee, it will become 4%, 3.25 and 0.75. But only 15,000 can pay, those who are earning 15,000 can pay ESI money. क्योंकि नंगा नहाएगा क्या, निचोड़ेगा क्या? If you are earning less than 15,000, how you can pay the premium? So this is also wrong. It is for 15,000 criteria. Employee has to contribute 4.75. No, employee has to contribute 0.75. So this is also wrong. Correct answer is B. And this question they ask again and again. that which program are funded by state and center both. Like for Ayushman Bharat, what do you think? Ayushman is center funded or state funded? Answer is both. Ayushman Bharat has 70% fund from central government, 60 to 70% fund, and remaining fund is from state government. So remember, in Ayushman Bharat, how much is state fund? 30%, 30 to 40%. How much center pay? 60 to 70%. So Ayushman Bharat is also funded by both center and state. Similarly, ESI we just discussed. ESI is funded by center and state. Similarly, one more thing is food adulteration. This food adulteration, it also come under both center and state list. So these three diseases have both center and state funding. Okay, this three area. And I hope you know everything about Ayushman Bharat. It's a very important topic in any exam, even if there is this NEET or INICET in both exam, this Ayushman Bharat question they ask a lot. So let's discuss this part in a bit more detail. In the Ayushman Bharat, I hope you know previously there was only two things, PMJ and Health and Wellness Center. But now there is three things, PMJ, Health and Wellness Center, and this Health and Wellness Center is known as Arogya Mandir. So nowadays they can ask question from Arogya Mandir. This is same thing as sub center and some PHC. They are changing sub center PHC into Arogya Mandir. Arogya means free from disease, so it is Health and Wellness Center or Arogya Mandir. And in PMJ, I hope you know, after hospitalization, 5 lakh insurance is given per year for family of 5 people who are below, who are not below poverty line, but which family get the money? Family which is economically weaker section. And this EWS are those who are earning less than 10,000 per month. For your PG reservation, EWS are those doctors who or their parents or them are not earning 8 lakh per year. Less than 8 lakh per year is EWS criteria for PG reservation. But for Ayushman Bharat, the criteria is people who are earning less than 10,000 per month. For 5 people, they are EWS. So EWS will get 5 lakh coverage after hospitalization. And is it for private or government? For both private government, because unfortunately, even the government is not free in India. So this is the two part. And the third part, as I said, is a school health program. That is also now included, because on Tuesday, we will celebrate Health and Wellness Day. But this Health and Wellness Center, when they're turning it into Arogya Mandir, they were people asked, what is the new thing which you will give? So they said, we will give total 8 things. How to remember this 8 thing? Very easy. First is dental. Then there is mental. Then mental means mental health, psychiatry. So dental, mental. Then whenever we talk about eye, with eye, which thing come? ENT. So eye, ENT, 4 thing done. Then for old age, we will give NCD treatment, diabetes, hypertension. So geriatric care, you can say. And in old age and all, post-operative, post-cancer pain, palliative pain care, hai na? Palliative care is also given. So old age has 2 things, geriatric care, palliative care. Dental, mental, eye, ENT, geriatric, palliative, 6 is done. Only 2 are left. One is emergency care, emergency trauma management. X-ray and ultrasound are not there at sub-center PSC, but somehow we will manage emergency. And last thing they gave was yoga, क्योंकि yoga से सब होगा. So these are the new things, 8 things, and because of yoga and meditation, they are calling it as Arogya Mandir. And these are the 8 things which will be given at Health and Wellness Center, which they can ask. So these 3 parts come on Ayushman Bharat, and Ayushman Bharat is funded by both state and center. So these were some of the questions which I kept this time for discussion. If you wish me to come with some other session, some part which you find tough, which you want me to discuss, don't hesitate to message me on PW MedEd. You can join the Telegram group, and you can message me on the Telegram group, which is Sankalp Telegram group, or you can directly WhatsApp me on my number 8860796675, and I will be more than happy to help you in any of your doubt or any of your topic which you think difficult before INICET or before MCI. If you want me to discuss those things, feel free. It's better if you will message directly to PW MedEd, because then I will get the direct order also. Plus, I can also answer your query directly on WhatsApp. So love you all. See you in the next session. Thank you so much. for this good session. If you have any doubt, anything to say, feel free and tell me. कुछ है क्या chat में देखना? Nothing. So keep enjoying the journey and keep, please follow my one request. Do 7 year of INICET minimum properly, and if you can do 10 and revise it 2-3 times, because many questions do repeat from the same topic which has been asked. Keep moving ahead, but do not forget to cover what is already being given. Okay, so thank you so much.